rarely metastasize to the placenta. Of those which do, melanoma, leukemia, lymphoma and breast cancer are the common ones. That's all I have to say. Thank you so much for the patient hearing.
Thank you, Payal.
Thank you, sir.
I'd just like to ask you one thing. As far as my knowledge is concerned, 100% of these abnormalities can be picked up by a good sonography.
Yes, sir, especially the anomaly scan. By that time, the
Yes.
placenta is well developed. Therefore, nowadays the ultrasound branch of gynecology is developing so much, because if we can detect this, we can also detect we can explain to the patient about the possible outcomes of the pregnancy.
So,
in this medical legal age, it's very important.
That's why if you do a good scan, I think you'll be deprived of the future consequences that you'll be taking off. My second question is that examining the placenta post-delivery, be it in a C-section or a normal delivery,
is a must.
Is a must.
Is a naked eye
but
examination.
What are the minute points that we need to look at? Because you have given us so much of other abnormalities.
So first we have to see whether the placental structure looks normal or not. Normal in the sense whether the membranes and the cotyledons are all intact, because there is commonest what we get is the chance that there's some retained cotyledon inside. Other than that, we have to see whether the margins are intact or whether there's some torn blood vessels. Because if there's some torn blood vessels, then there's a chance that there may be some accessory lobe inside. Other than that, grossly, maybe few calcifications again can be seen if there's advancement beyond 40 weeks. But rest of that can be only done by pathological. But at least we can assure that there's been no retained placenta inside. Placenta looks more or less normal without any lesion, and there's no major blood vessel tone. And of course, then from the history, there should not be any antepartum hemorrhage, because if there's a history of antepartum, we have to look for any bleeding vessel. It may be a vasa previa, which we have inadvertently during our PV examination ruptured.
I'd like to add one more. To examine a placenta macroscopically, it must be allowed to separate spontaneously. If you do a manual removal in C-section, I think we are only losing a lot of information that way.
Exactly. And we should never hurry about that, because that little transfer of blood from the mother to the baby is definitely advantageous. So do not pull the placenta, let it separate.
Yeah, if I'm allowed. Thank you, Dr. Payal. It was a wonderful lecture. In fact, I have already been fascinated by placenta and cord anomalies, and I'm very happy that for the first time I'm hearing a lecture about it. I keep telling my postgraduates, there is area, we just keep thinking the placenta is 25 centimeter long, 5 centimeter broad, and this thing. And
it is 500 grams at
500 grams. I said,
15 to 20
cotyledons. Like in Safdarjung, they have 10,000 delivery per year. I said, just do research. Maybe it is 450 gram only, Indian placenta. Maybe
because of the baby, the ratio is 1:5.
And same way, say 1% incidence of this core, this thing also. I think there is a real need to examine the placenta. Usually, placenta is just
it gives us a lot about the antenatal history.
After the delivery, placenta is just thrown. Nobody examines it carefully. I mean, such a fascinating organ. So much information can be had from it. There is a need to do. I mean, the postgraduates without any funding, you can correlate. Just find out in 500 deliveries.
Okay. Zedi, I'm sorry to interrupt. Madam Payal is allowed to leave the podium because of her this scheduling of her flight. So we can continue.
Very good lecture. Thank you.
It's your journey, and thank you for the wonderful presentation.
Thank you, sir.
Sarmaji, you can continue. You can continue. But felicitation has to be done.
Okay, thank you, sure. No, that's what I just want to highlight, that, it's a really wonderful lecture and there is need to redefine it, and I think we should thoroughly examine the placenta and can correlate with pathologists also. We can find out, like, normal placenta versus pre-eclampsia placenta, normal placenta versus some other pathology. So postgraduate can take this as a thesis topic, or SR can do this small thesis or small work on this, easily publishable also. So please do work on the placenta and cord anomaly. Thank you.
Next we have a wonderful presentation from Dr. Sangeeta Samar, New Delhi, on the topic adolescent tuberculosis, a cause for future infertility. Please welcome Dr. Sangeeta Sharma.
Can we start? So, this is a concept, sir, which I came to realize while I joined this institute. My institute is the National Center of Excellence for Pediatric TB and DRTB. So, can I have my presentation, please? So, it was initially an observational study where, I started to ask about the menstrual pattern of adolescent girls. And to my utter surprise, yeah. So, ये relay नहीं हो रहा इधर.
It is coming. Is it?
Okay, it's coming. So, I realized that adolescent tuberculosis could be a cause of future infertility. So, the background is that tuberculosis, we all know that it's a cause of mortality as well as morbidity. And menstrual dysfunction and genital involvement, they have great incidence in cases of tuberculosis in adolescent girls. So we just did an observational study, and that later on it expanded, the study was to evaluate the menstrual dysfunction and genital involvement in tuberculosis, both pulmonary as well as extrapulmonary. The material methods were that it was a prospective study over a period of 8 years, where all the girls who presented with tuberculosis, we asked about their menstrual history, and then detailed history, demographic profile, and then also we tried to do the menstrual blood in those girls who had some menstrual flow coming. But majority of the girls, they had, oligohypomenorrhea, which I'll be discussing later. And we sent this menstrual blood for the CBNAT, the rapid molecular test, and also culture. And the ultrasound findings, and if required, a PET CT or a MRI was also done. And CA125 antigen to differentiate between, if there was a TO ovarian mass, it could be ovarian cancer malignancy. So to differentiate, we did that. So 265 girls were enrolled. The mean age was 14.2, and all girls, they belonged to socio-economically backward class. They were 80%, and all were unmarried. So that was the reason we could not perform, because the girls were unmarried, we could not perform the endometrial sampling or the transvaginal ultrasound. So the correct categorization was very important. The first thing which we did was in ultrasonography, and this was followed by, depending upon the diagnosis of pulmonary or extrapulmonary tuberculosis, 2 subsets were formed with genital involvement and without. And now coming to the girls, majority, 60% had pulmonary tuberculosis, while 35% they had extrapulmonary tuberculosis. And now coming to the menstrual dysfunction, except for 10 girls, who had, none of the girls had normal menses. This is very, very important, It is almost universal. This is one thing which we really need to understand, that all the girls, they had some menstrual dysfunction, be it primary, secondary amenorrhea or oligohypomenorrhea. Ultrasound was done, which showed, in some it showed, picked up, the tubo-ovarian mass or the involvement of the endometrium. And like in this case, the transvaginal ultrasound, because this girl we were able to perform the transvaginal ultrasound because she was sexually active. There was a ovarian cyst with solid as well as cystic masses and the fluid level. Then a PET CT again showed, this bilateral adnexal mass, which was cystic, and there was mild FDG uptake. So this is an important differentiating point for whenever you have malignancy. The FDG uptake is it is much more. While even in tuberculosis, the FDG uptake is there because it indicates activity, as you can see in this arrow. And then, coming to the MRI, MRI was a very useful investigation which could differentiate, more clearly define the lesions. So MRI was a preferred investigation. And now coming to the microbiological results. In microbiological results, majority of the girls, they were diagnosed cases of pulmonary or extrapulmonary tuberculosis. And with the genital involvement, there were only 10 girls. Rest, even without genital involvement, almost it is universal. Even if you do not have any genital involvement, still the girl will have show up in her menstrual dysfunction. So this is a very important finding which I realized. And then we also picked up multi-drug resistant tuberculosis, female genital tuberculosis, already published in European journal. So now coming to the treatment. The treatment, as you all know, now the treatment is all depending upon the correct categorization. Suppose it is drug sensitive tuberculosis, then we start the 6 months therapy. Then we have another different regimen for INH resistant treatment, and MDR-TB now we have shorter as well as longer MDR-TB regimen. But mind you, whenever there is genital involvement along with pulmonary or extrapulmonary tuberculosis, it automatically fits into a sphere kind of involvement, that is sphere kind of MDR tuberculosis, and then the child cannot be given, or even the adult cannot be given the shorter MDR-TB regimen, the 9 to 11 months. So directly you have to revert to the 18 to 20 months of long all oral regimen. So this is very important for children as well as for adults also. And if you are unable to pick up the organism, then depending upon the history, if there is a history of contact, then based on the contact, then the regimen is designed. But one thing is clear, the severity, as I said, if it is genital involvement, it automatically goes towards the severe forms of disease. So the thing which is the result of effective and early treatment is 21 girls without FGTB, 17 had pulmonary TB, and 4 with extrapulmonary TB had normal menses. These were those girls who were started treatment ATT within 1 month of diagnosis of developing tuberculosis. And the other thing which is important to understand is that the earlier you start the treatment, the better it is. So, and their menses, they reverted back earlier, with adequate treatment. And in rest, the response is partial. So, girls with genital involvement with MDR-TB or severe forms of tuberculosis like TBM, or other disseminated like miliary disease, they had a poor response. So there are very few studies showing the genital manifestations of pulmonary tuberculosis. Tripathi, they published their data in 1981. So this concept has been there since 1981, that the genital involvements they found in 13% of children, of the ladies. And amenorrhea was one of the important menstrual dysfunction. Again with genital involvement and without genital involvement. Same true for Semel et al. And my findings of menstrual dysfunction, I have also published this in International Journal Obs and Gynae in 2002. So as I already stressed, be it pulmonary or extrapulmonary tuberculosis, primary amenorrhea, secondary amenorrhea, oligomenorrhea, only 3% of the girls had menorrhagia. These were those girls which were started treatment, or they were picked up, very early. So probably their endometrium had just been involved, and it was in the reactive phase. So these were only the 3% girls who had menorrhagia. And involvement of amenorrhea and infertility in patients with extragenital tuberculosis with no involvement of genital organs is a poorly understood concept. But this is now emerging concept, and it has been found that the mycobacterial antigen, it has an antigonadotrophic effect. So that is the reason behind all these findings. And now to end my presentation, the take home messages from this is that there is a very high prevalence of menstrual dysfunction in tuberculosis, both pulmonary as well as extrapulmonary TB, which may be responsible for future infertility. And patients with severe forms of disease like drug-resistant tuberculosis, miliary tuberculosis, tubercular meningitis, or disseminated forms of disease in which there are more than 2 organs involved, they are associated with early onset and more severe menstrual dysfunction. And early diagnosis and start of timely effective treatment results in early resumption of normal menses, and this may prevent permanent damage to the genital organs and future infertility. Thank you so much for your patience. Hearing, please. Thank you. And in the end, this is always my favorite slide because I always like to thank my children who, the reason I'm standing here is just because of them, because these are the children who have treated over the years. Thank you so much. So my last thank you is always to my own children who I've treated as a clinician. Thank you for your patient hearing. Thank you.
Thank you, ma'am. Just be there. I think there must be certain queries from the house itself because you have really opened up a Pandora's box as far as I am concerned.
Yes, sir.
Is there any question from the house?
Sir, just to give you a brief up, this concept, I have presented this and I've been asked to present this in Tokyo, in Asia-Oceanic Conference of Gynae, then also in Melbourne, FIGO, Brazil, FIGO, then also in FIGO in London. So, whenever, wherever, and now even in our Union Conference of World Lung Health, this paper, it was picked up by the Union and I was eligible for the press conference because, this is very important and it's an ignored topic. This is what I feel.
Is there any question from the house?
Yes, ma'am.
I think this is really very, very interesting finding, and in fact we do come across with this kind of problem. I had a patient who had a severe menorrhagia, not responding to anything, and within a few days, say within a month or so, she developed psoas abscess, cold abscess.
Yeah.
That's sometimes it is so bizarre, the presentation. Yeah. And of course you have amenorrhea and all those things, but it is very important to have those menstrual problems in pulmonary tuberculosis as well.
Yes, ma'am.
Yeah.
Pulmonary, extrapulmonary tuberculosis of any part of the body. As I said, the mycobacterial antigen, it has got an antigonadotrophic effect. In your case, it would be initial involvement of the endometrium, which results in menorrhagia. In my initial study, which I published, 3% of the girls had menorrhagia. Because that shows that the endometrium is getting involved. So it's in that hyperemic state. And later on, it leads on to something like Escherman. Yeah. Because the tubercles they set in, they cause fibrosis, etc.
Yeah, thank you.
What I also want to highlight, I had also done a lot of studies, and thanks to Sangeeta, I got interested in the subject. So what happened initially for the postgraduate and others, there are tuberculosis when in TB endometritis will cause ulcerative lesions on the endometrium. So at that time, patient will have menorrhagia. And we even last month only we had a patient of postmenopausal bleeding and endometrial biopsy showed to epithelial granuloma. It can cause postmenopausal bleeding also, perimenopausal bleeding also. So ulcerative phase it will cause menorrhagia, but later on tuberculosis will eat away the endometrium. And then as madam said, we have oligomenorrhea, hypomenorrhea and even amenorrhea. But those patients like she showed pulmonary TB and all, they may be without genital involvement. So it is because of the toxins of the mycobacterium in severe forms of disease which has antigonadotropic effect. And this we have seen in other diseases also, sir. Whenever the girl loses weight, like anorexic girls and or other severe diseases, they often have oligomenorrhea and amenorrhea. And by timely treatment of that particular disease, maybe psychiatric disease, maybe any severe form of the SLE or any other medical disorder, in which girl loses weight, and if her weight becomes less than 37-38 kg, then they go into oligo and have amenorrhea. So this may be, 2-3 mechanisms may be working. So
to both the Sharmas, I came across some patients who had history of pulmonary COX 20 years ago and came with genital tuberculosis.
Later,
how to explain later in life? Secondly, what should we do to diagnose genital COX at the contemporary practice now?
Okay, very good question. So in fact, whenever I'm seeing patients of genital TB, past history of TB is very, very important. And most of these girls had pulmonary TB in the past. But this is that history may not be coming because this she had in unmarried state, and this fact she has hidden it from the in-laws families. So I always take her into confidence that I'm not going to tell your husband or your partner, just tell me. So then she comes out, okay, I had, or sometimes what happens is they had, when she was a small girl, she looked after her dying father, grandfather, grandmother who died of pulmonary TB. I'm seeing, and usually the girls look after, I wish it's the boys actually, because then the girls can get the disease. So past history of TB is very, very important. Past history of family history is very important. And at that time, what happens is that at that time the disease was controlled by ATT, but the bacteria did not die, just left somewhere. So whenever then there is a decrease in immunity, this is what happens in tuberculosis, sir. Mycobacterium just lives somewhere in the body, and whenever we have immunity goes down, we lose weight, or like after marriage suddenly, there are so many changes in the girl's life. So at that time then it can manifest. And it has happened, I have seen some 2-3 ladies I've seen, they went to lose weight. So they took this herbal treatment in which they were given a lot of water and some herbal drinks and total cut off of food. So they lost 10 kg weight, true, but 3 of them had developed tuberculosis. So which was lying silent somewhere. So mycobacterium is known to stay dormant in the body, and whenever body immunity goes down, like someone got HIV, someone got any immunity, or you take anti-immunity drugs after say renal transplant or anything, then the disease comes back. So in fact what happens is most of us may be having, in fact I may be having mycobacterium in my body, in childhood probably, but this is lying dormant. So if our body resistance goes down, we lose weight, that is the time when it comes back. So past history of TB is very, very important. In my 60 to 70, 55% patients in my study had past history of TB in the family, in herself and all. In fact, just recently I had a patient from very top family, don't think it's disease of only poor, top family girl, married to family, and my HOD medicine told me that he had treated her as pulmonary TB before marriage, but this fact has not been told to the husband, to don't disclose it. So I was given. So I saw them as a fresh case. I did laparoscopy on her and this patient, and she had very 5 into 4 centimeter TB nodule on one side. I have never seen almost like a white ball, and I have even published it as a snowball. It's after my name. It's on PubMed. You can see snowball sign. Such a 5 centimeter I have never seen, almost the size of the uterus. And then I gave her ATT. Her tubes could not even be seen. I said, you just go for IVF after treatment. So she went for IVF, and 2 months back she rang me, okay, sir, they want to do cesarean on me. I said, did you fall pregnant? So she was on IVF. She fell pregnant. They did a cesarean. She had a baby girl. So she has sent sweets back to me. I never thought she will ever have pregnancy. So this past history is there, but this her husband doesn't know. This is, it's okay. So we never disclose it to them. This is important. But sir, past history of TB is very, very important for them. So this concept, I feel, it is causing disease, and many girls can be prevented permanent sterility, as Sangeeta has said in her presentation. So I think we should keep an eye about it and this thing. So that is important. So
how should we? How should we diagnose genital COX in the contemporary?
As gynecologists, we see them as in married state, and most of them come as menstrual dysfunction, so usually infertility. So routinely on day 21 to 23, I do endometrial sampling on them. I send in a sample for AFB microscopy, AFB culture, gene expert, CBNet, what she said, and then PCR usually is not that much reliable, and histopath granuloma. And if you find, or you are suspicious of TB, sir, or there are some TO masses on ultrasound, or there is oligomenorrhea, hypomenorrhea, past history of TB, that makes us sensitive. So there is a composite reference standard. I won't go into detail of that, But if you are suspicious of TB, do a laparoscopy dye test on her, laparoscopy, histoscopy I do, which is done in any way because we need to know her tubal status. It's not unethical to do. So on laparoscopy and histoscopy, you have subtle findings. Sometimes the definite finding, like you had tubercles, cages, nodules, and BD tube. They are definite finding. Then you have probable findings: stalk-colored fluid, perihepatic adhesions, intestinal adhesions, peritubal adhesions, hydrosalpinx, pyosalpinx, steomas, like that. They are of probable signs. And there are some possible signs also. And then on histoscopy, you have pale endometrium, Esserman syndrome, adhesions, and small tubercles, cages, nodules. Like that you can have on histoscopy also. So in the same sitting, I do under general anesthesia, laparoscopy, histoscopy, take sample. You can take biopsy also. But quite often, even if you send the granuloma, cages, nodules, it may not show anything. So, but just by observation, you are allowed to do diagnose tuberculosis, and then I diagnose laparoscopic evidence of tuberculosis. Okay, ATT category 1 to be started in India. I send them to DOT center. So you can use the facility of DOT center. When free drugs are given by this thing, they get 500 rupees free from Pradhan Mantri Yojana also, and free medicine RHZD daily for 2 months, RHE daily for next 4 months. So this they can give, and then they can't refuse. They sometimes they grumble, they don't want to give to non-pulmonary TB patient. Actually, program doesn't want to give, but they have to give it because you want to use. So I have seen in early stage timely diagnosis and treatment, as I showed in this case. So you can achieve pregnancy, and usually at the end of the therapy, I tend to repeat laparoscopy, histoscopy again and biopsy on them, madam. That is important. At the end of the 6 months, like I do laparoscope, so there can be 4 scenarios. If tubes are open, histoscopy, endometrium is fine, they can go for ovulation induction. If tubes are blocked, endometrium is fine, they go for IVF-ET. 30% patient go for IVF-ET, good results. But if tubes are blocked, endometrium has grade 3 or more adhesion, which you can't cut histoscopically, then she goes for surrogacy, provided her ovaries are fine. But I have seen in 1 to 2% patient, even ovaries are eaten by the TB. So ovaries also disappear, or they have hardly any follicle. Then this patient goes for adoption. So at the end of 6 months, I sit with the couple and tell them frankly what is this thing. They cry. But I said, don't sell your house, don't sell your, land, and they sometimes go to with all apology, find a private practitioner, don't offend to anyone. But they sell, and nothing comes to them. So I just tell, they say they cry, but ultimately they say, I just said, just to adopt a baby, don't cry, like that. So you can scientifically take it. So at the end of 6 months, you can again do laparoscopy on them for prognostication of the disease and for proper planning of that. But 30% patients ultimately require IVF-ET, and results of IVF-ET are quite good in them. 20 to 25% success in our IVF patients. I refer to I don't do IVF, my colleague do, but I refer them to them after this. And this case, I told you, I couldn't see tubes, ovaries at all, just such a big nodule, 5 centimeters. That is on PubMed. You can see, Sarma snowball sign. It's easily downloadable. And this patient had IVF, and she had female baby, 2.8 kg, and it's a very happy success story. So thank you very much.
Madam.
Yeah.
I'm so happy that I came today, and I have learned a very valuable lesson today, ma'am. Since I deal with postmenopausal women's health, so many cases of postmenopausal bleeding comes to me and towards the toe. And whenever we have postmenopausal bleeding, this thing goes to onco session, like any other thing. So it is a very, very good lesson I learned, that we need to look for this in TB also. Thank you, ma'am. Thank you, ma'am.
Ma'am, one particular question, last question from my side. You are looking at the new era of diagnosis of irregular menses or heavy menstrual for an adolescent in the angle of tuberculosis, right? Suppose there is no past history, we have spent enough of time. What would be the investigations to look into this subclass of adolescent girls who are presenting with menstrual irregularity without other endocrinal problems? How do you look into them?
So this is what I said, it is universal. Whenever there is a case of tuberculosis, be it pulmonary, be it extrapulmonary, even without genital involvement, the menses, they will get affected. I mean, I've been observing this for last 25 years. I'm working in my institute. This is a National Center of Excellence for Pediatric TB and DRTB. So it is universal. And now the reason is because the mycobacterial antigen that has got an antigonadotrophic effect. But mind you, despite that, always one should get an ultrasound done, because my patients are unmarried girls. But for you who deal with, sexually active females and women, I mean, it's always worthwhile whenever
I'm actually talking of those adolescent girls who are not sexually active, because we have to diagnose, or can we just start an anti-tubercular treatment for any girl who is with irregular menstruation or
No, sir.
That's what I'm looking at. What
You have
investigations
to,
we
sir,
should...
menstrual dysfunction, one of the causes is tuberculosis. There are other causes of menstrual dysfunction also.
So
But
what would be the right investigation to look into that subclass to diagnose tuberculosis? What investigations we are
Sir,
recommending?
investigations tuberculosis, the first and foremost is just get a plain X-ray chest, because X-ray chest is a very good screening tool. And if the chest X-ray shows lesions, then obviously you send the sputum, because it's very difficult. You are unable to get hold of menstrual blood and to start collecting samples from the the genital, the tubo-ovarian. The easy accessible sites are sputum, and then always palpate for cervical lymph nodes, because cervical lymph nodes, they are the commonest site for extrapulmonary tuberculosis. So if chest X-ray is normal, then look for the cervical lymph nodes, and also there is no harm in getting at least sputum microscopy done, because that is very inexpensive and does not cost anything.
Thank you. Thank you.
I had two girls. I admitted that she was niece of one of my class fellows, ex-class fellow. So she had TO-mass, unmarried girl. So TO-mass, I thought it could be germ cell tumor, but it didn't look like, and couldn't do PV on her unmarried girl. So I got her admitted. I said, okay, we'll admit her, we'll do investigation on her. And next day when I was taking the round, we, admit the patient from, it was crowded OPD. And so then we thoroughly do. So when I examined her, she was having some discharging sinus from her left knee. And then we sent the sample, it grew tuberculosis. Another girl I admitted, sir, she had, as she said, cervical lymph node. So we took FNAC from there. I was thinking that, I was talking to my microbiologist that can we take FNAC from TO-mass and all, but we were just planning, and I was very hesitant to put a needle in a TO-mass in an unmarried girl. So we took this and we took from there to grew TB. So please do carefully examine the girl in totality, whole body. Somewhere you can find small lesion, which is more easily accessible for looking for a FMI.
Yeah, I mean, examine the patient as a whole. And the other thing is, sir, because adolescent is another age where, you have the germ cell tumors coming up. So I've had referrals, sending me cases that this is a drug-resistant tuberculosis, not responding to TB treatment. But it was wrongly diagnosed because it was a ovarian CA. So we have to keep both the things in mind. In that case, again, the PET-CT will show more of the uptake, as well as this CA125 antigen levels will also be very, very high, in the range of, more than 500, while in tuberculosis less than 100.
Yeah, this also just last point on this is very also important. Like, sir, we did collected 26 cases from AIMS, MAMC, Lady Harding, GTP, where we did laparotomy for ovarian CA, turned out to be tuberculosis. But I'm seeing patient other way around also. That means patient given ATT, just last 2 weeks back I had this patient, he was given 3 months ATT. And now she has become stage 4 ovarian cancer with pleural fluid also showing adenocarcinoma. So that is a bigger sin. I mean, it's in doubt, it's better to open and treat the patient. Yeah. So this is very, very crucial for this.
I think we had done excellent learning in this particular session. Not only the delegates, probably we also enhanced our knowledge. And thank you all the speakers for a very high level discussion that we had around.
Sorry, ma'am.
It can increase, madam. Up to I have seen up to 1,000.
It increases, but it's I mean, usually in the range of 100 to 200 in tuberculosis, while in CA the levels are much higher.
Just one last point, sir. Sorry, we are getting delayed. A good ultrasound scan is the simple modality which you should, whenever you suspect, as you were asking that question, no, sir. A good ultrasound scan from person who has done scan for this. Like I sent this friend to Dr. Shokran in Delhi. He has special interest and special expertise in picking up cases where it was labeled normal ultrasound scan by another colleague, but then I referred the patient because suspected TB, as you said, those in your case. That patient is having oligomenorrhea. I feel she may have. So I referred to him, I said, you do scan yourself, don't get it done from your assistant. And he did, and he picked up minor, very subtle sign, like some fluid in the cavity, some stroke, some fluid outside the cavity, and some thinning of the endometrium. So very subtle sign he was able to pick up. But so someone, not to offend to other ultrasonologists, but someone who has done more cases and who is special interest in that. Similarly, whenever I send sample for microbiology also, sir, a routine microbiologist may fail to pick up the case. So the person who is specially in test and expert in that, same with histopathologist.
Sure.
So this is important.
Thank you.
Thank you, sir, for giving me this opportunity and adjusting me over here. Thank you so much.
So we declare this session closed. We took little overtime, but I think knowledge always has no limit. Thank you.
Comprehensive and knowledgeable presentation. I would like to request our chairperson to kindly felicitate our speakers. I would like to request Dr. Asit Kumar also onto the stage for the felicitation. Thank you, chairpersons, and thank you, speakers. Moving on to the next session, we have regenerative and functional gynecology session. For this, I would like to request our chairperson, Dr. N. Suboda, senior consultant and head of department, Department of Obstetrics and Gynecology, Caesar Hospitals, President IOGS, organizing chairperson, FOGSI is Zonal Conference with Yuva 2023, and Dr. Netajini, Professor and Head of Department, Department of Obstetrics and Gynecology, JENIMS. I request our chairpersons to kindly chair the session.
CV. You have the CV? We can project it there. Good morning, ladies and gentlemen. Age is just a number. It is the psychological age rather than the chronological age that matters. But looking young helps one thinking young. Cosmetic gynecology is a relatively new entrant to gynecology, but rejuvenation and cosmesis is the in thing now. And with everyone thinking young and wanting to look young, this is the trend at the moment. Dr. Sabna Somtham, if we talk about cosmetic gynecology in the state, she needs no introduction. She is the pioneer in the state in cosmetic gynecology. She is founder and chief Managing Director. Sabna, she met us Academy in Imphal, and she has got centers in 7 centers all over the country and outside the country in Nepal too. In fact, she has put the state in the global map in cosmetic gynecology. She is advisor in Sexual Medicine Cosmetic Committee, FOGSI, Joint Secretary, INSARG, Senior Member, European Society of Aesthetic Gynecology in Edinburgh. She is Master Trainer and Coordinator, Fellowship, Complete Feminine Aesthetics and Cosmetic Gynecology. And till now, she has trained more than 75 doctors from over the country and even from outside the country. So, the floor is yours, Dr. Sapla.
Thank you so much for the kind introduction. Can I have this? Thank you so much for the kind introduction. And first of all, I would like to thank the organizers for giving me the chance to share my views on a topic which is very, very close to my heart. Cosmetic gynecology, then, now, and future. There's a lot to talk about, but since there's a time constraint of 15 minutes, I will try to put everything in 15 minutes. What is cosmetic gynecology? It's a branch of science, it's a subspecialty, or rather I would call it super specialty of mainstream general gynecology, deals with functional and regenerative and cosmetic issues of the woman, both internal and external. When we go to the history worldwide, it started as early as 1st century AD, where they have done clitoral ligation. They used to think hypertrophic clitoris is not good for the woman herself, and especially when husband goes for a long war and all that, they used to ligate the clitoris to subdue the sexuality of the woman. It is more of female genital mutilation, not cosmetic gynecology. And so it evolved, but the one who had done the actual cosmetic gynecology, actual good work for the woman, episiotomy has been given by Trotula. She was a midwife, but she had given an official episiotomy which has been accounted in the written textbook. Also, I have the privilege of conducting the first cosmetic gynae workshop almost all the states and abroad also, even Imphal, Jharkhand, Nepal, Japan, almost everywhere, Dubai. Then, when we talk about then, when we started about talking about cosmetic gynae back in early 2000, 2003-4, we have started to empty hall. We used to talk, if we were lucky if we have one person to chair and one person to click my photograph. And now number one, trainings. Trainings were very, very costly. If for my training I had to spend nearly 15 lakhs abroad. So, nearly 20 lakhs we had to spend back then. Now I'll be talking about now also. Also, inability to accept from doctors also. People used to ask, Savannah, what are you doing? And especially when I started doing 360 degree. Can you give me my? When I started doing 360 degree women this thing health. Actually, I started doing because Imphal being a small state. When I said vaginal tightening, people used to feel shy. So I used to say that face rejuvenation. So somehow I started with face rejuvenation, but now we're doing quite okay. But why I have started doing the face rejuvenation is because in a small state like Imphal, it's very difficult for me to say vaginal tightening. And even my friends, gynecologists used to say, wow, wo kar rahi hai. Then they'll say, she stopped doing everything, she's only tightening. And patients who used to come to my clinic were made fun by their friends. Oh, Savna ke paas ja rahi hai, wo karke aaye aise. So, from there, just to make the patient feel comfortable, I used to promote it as the face tightening. They used to come, I did not know how to give Botox also. Now I'm quite okay. Then they will have some bruises, then they are happy. Oh, I had gone to do some bruises. But they will do the vaginal tightening. But now we have completed more than 10,000 procedures in energy-based devices is sort of a record in our state only. These days I have patients from outside also, but main patients are from our state. I did not say 10,000 patients, I said 10,000 procedures, because per patient I have done more than 5 to 6 sittings. And machines were very costly. As Dr. Arun also will be knowing, the first machine which we bought, nothing was no machines with less than 40 lakhs. So if I want to start a cosmetic gynecology center, I have to spend at least 80 to 90 lakhs, around 20 lakhs for the training and machines, 40 to 50 lakhs. But now everything has been changed. Now is the golden era of aesthetic and functional gynecology. Everybody wanted to join. Now I am used to giving talk on mommy makeover, and once I had posted in the FOGSI friends about mommy makeover. Many senior gynecologists said, Savannah, why, and not only to me, why are you putting such a topic for this one, our AICOG? Now the person who posted came to me for training. Then I said, okay, I have arrived in this field. Now golden era of this cosmetic functional and cosmetic aesthetic gynecology, and we are giving 360-degree care, and mommy makeover, which has been trademarked by me, is the in thing at the moment. We have surgical and non-surgical. Non-surgical options, I use all these EVDs and many other procedures for this one non-surgical of our cosmetic gynae, aesthetic and cosmetic gynae procedures. Energy-based devices, we use energy-based devices. We have radio frequency, laser, HIFM, HIFU are the main things. And we use FOGSI, we use ULT therapy, etc. But these 4 are the main things. When we talk about radio frequency, we have monopolar, bipolar, and the unipolar. Mono and uni are not same. Uni has been patented by Alma. It's a little different, but it's out of the scope for my talk today. Radio frequency, what does it do? It's a part of electromagnetic spectrum where the frequency range differs from the industry to industry. In medicine, 1 megahertz is optimum RF. So what we do, mainly radio frequency, when we talk about the delivery to the patient, we can say continuous RF, we can say MNRF, fractional RF, we have other forms of RF also, but in continuous RF we talk, it's more about tissue contact. It's more about tissue contact in the sense that we are raising the radio frequency when on the face or on the body, skin or the vaginal area of the patient. So now we are giving kinetic energy, which has been transformed to thermal energy. Now thermal energy gives controlled tissue damage. To give rejuvenation for collagen remodeling, we need to destroy the tissue. If we do not destroy the tissue, we cannot give remodeling. So we give controlled tissue damage to this thing. Mine is more of, when I talk, I usually talk of what I actually do. I have about 10 to 12 machines at the moment in my center. This is monopolar radio frequency, vaginal rejuvenation. This is the monopolar radio frequency, labial rejuvenation. And this is again, now this is MNRF radio frequency, microneedling for labial rejuvenation. And again, this is matrix, RF matrix for labial rejuvenation. And the monopolar RF, by virtue of the when being smaller, we can go to the perianal area also. And for vulvodynia and vestibulodynia, we give botulism toxins. But as a post treatment, we give this radio frequency in the perianal area. This can be used even in the rectal area. This can be used only even in the rectal area, and it can be used for treating our hemorrhoids also. This is a bipolar radio frequency, and the monopolar and a bipolar, it differs on the energy delivery system. And this is a bipolar radio frequency working on the labia. This is MNRF, microneedling of the radio, MNRF microneedling, and this is MNRF inside the vagina. This is a new addition to our cosmetic gynecology, a boon to the cosmetic gynecologists. This machine is inserted, this handpiece is inserted to the vagina, and a microneedling is done in the vaginal canal. Now when we talk about laser, full form of laser is light amplification by stimulated emission of radiation. Concept has been given by Albert Einstein, but now again one of the Indians have started giving the fractional CO2 concept back in 1958. It was one Indian who have started the fractional CO2 concept. Now this is the we have two types. One is this one, volume. So now we have one is ablative and a non-ablative. Laser works with the principle of chromophores. Like there are three chromophores in the body. Chromophores are the things which is color. Three chromophores are melanin, hemoglobin and water. Since vaginal canal almost 95% is water content, we work with the laser with the wavelength which is nearer to the water. Both one is LVM YAG and one is fractional CO2. Both wavelength is nearer to the water. So we are using this laser for this one, vaginal rejuvenation. But then there is one more thing, there is non-ablative laser. Not all lasers are ablative. We have at one end of the spectrum, we had ablative laser. At another end of the spectrum, we had radio frequency. So we were thinking, I want something in between. I don't want as ablative as the ablative laser, but I want something more than the radio frequency. Now we have this LIRA, 1470 nm diode. This is non-ablative laser. I want the volume. Now this is a 1470 nm diode in my clinic doing vaginal rejuvenation, and this is for the labial rejuvenation. Labial rejuvenation can be done with monopolar RF, bipolar RF, which non-ablative laser, it can be done with HIFU, it can be done with ablative laser also with fractional CO2. Now comes HIFU. HIFU is another recent addition to the field of cosmetic gynecology. As far as I know, we never used to use HIFU for cosmetic gynecology, but it's turning out to be a boon. But only thing is HIFU, there are too many parameters. We need to use all the permutation and combinations of our angle, length, pitch, power. Suppose like it cannot increase everything. If you increase pitch, then you have to increase the power. If you decrease the angle, you have to decrease the power, etc. If you learn HIFU properly, it is a golden instrument for vaginal rejuvenation. Then we have high FEM, high intensity focused electromagnetic waves. High FEM, one plus one is it can be used by this one also, male also, even for premature ejaculation. Combination therapy is one thing which I actually try out. Not many people do combination therapy, mainly because it's costlier to buy all the machines. There are very few centers, I should say, in the world where someone has all the machines. I've installed all the machines mainly because I conduct trainings. When I conduct trainings, the candidate have a right to see the machines. So combination therapy is a boon. I can start with HIFU and do a radio frequency in the same sitting. Then I can, after 1 week, I can give high FEM. After 21 days, I can give laser. In the next sitting, I can give ablative and a non-ablative laser. Now this is some of the before-after pictures. Okay, continues in the frag, some of the before. Surgical, one of the most distinct reason why lady in Imphal come to me is for the labial asymmetry. Labial asymmetry, there are three types of surgery. One is for the labiaplasty. We have three types. One is simple curvilinear resection, what is waves, and one is our Z-plasty. We have other device others also, but officially and traditionally we have these three. This is again labiaplasty done with this is the end result of that labiaplasty. Okay, this I am using 1470 nm diode laser handpiece for the labiaplasty. Okay, now this is I have branches all over country. Dr. Amita here is she had opened my franchise partner. First time I have done labiaplasty in an unmarried girl. She came to Amita with the first thing. So she did not like the labia. We had done labiaplasty in Dr. Amita's clinic. The result is fantastic and the patient is happy. First time of the non-married girl undergoing labiaplasty. This is for the anterior vaginal wall prolapse, which we have done with HIFU and radio frequency. This is second sitting. One of the contraindications for energy-based devices is third degree UV prolapse. But recently I have tried and getting good result. I will share the before after picture iske baad mein. Now this is G-shot. G-shot is an injection of the hyaluronic acid. Pre-filled hyaluronic acid in the Z-spot. Very good this thing we have it here. This is sexual enhancement. I give labial thread. That is for labial rejuvenation. Then we have, one more thing I have done is lichen planus sclerosis. This is one new thing which I have done before treating lichen planus sclerosis. I had gone through many papers, whether people are actually doing it, whether it's legal or not. So there are so many studies, published papers where people are treating lichen planus sclerosis, which the frequency and the fractional CO2. But of course, before we tackle a lichen planus, then we need to take biopsy from different sites, not only one side. Make sure you're protected, and we do monopolar RF. Monopolar RF I use for the simple reason monopolar is the deeper. For lichen sclerosis, I do not use bipolar RF because bipolar depth is in between the half the distance of the two electrodes. Monopolar goes deeper. So for lichen sclerosis, monopolar is better. This is for the clitoral hoodectomy. We have two types: clitoral hoodectomy and hood reduction. I like hoodectomy, but clitoral hoodectomy is another one which we have to be careful. There is a thin line of difference between female cosmetic genital surgery and female genital mutilation. Our clitoral hoodectomy I am doing because I want to enhance sexuality. Now, we are in the process of doing clitoral hoodectomy. If I damage the nerve endings which is there, it's a very, very superficial injection. Then I will be doing more of genital mutilation. This is just before I did hymenoplasty. It's a relatively easy operation. We refresh the edges and I sutured 3 layers. We need 40 Vical Repride. My stock Godova is not available in Manipur also. So the person got a new stock, so I'll be doing more of. And believe me, there's so many girls who is coming for hymenoplasty. Hymenoplasty is actually as an empowered woman who, as a lady who like support women empowerment, we feel that what is there in hymenoplasty? But it's a male ego. Male want to break something when they have the first sexual encounter with a woman. So play with the male ego, give them something to break. They will break it, they will be happy, and will earn money, and no one will be the wiser. Now the recent is 360-degree mommy makeover, which has been trademarked by me. We do body reduction, arm toning, do everything. Most of the pictures are local VIP, so I cannot share. I even go for rhinoplasty, non-surgical. Okay, this is the radio frequency. Okay, this girl had given permission to me. So matrix RF, I do only 15 minutes. I usually take half an hour, but today only 15 minutes. RF pain is for active acne. We get very good result. Active acne, even the mark is gone. That is usually when even I have little dropping. But thing is like, I want to do things myself. I need an appointment with Dr. Savannah, but then I am not getting an appointment with Dr. Savannah. Everybody needs rejuvenation. You know, Dr. Subodha said that is the in thing. Coco Chanel said that if you are not beautiful at 20, it is okay. But if you are not beautiful at 40, you are simply stupid. You have to be beautiful. You can be beautiful. You can look like whatever you want at age of 40 if you can afford. Give me 5 lakhs, I will change it to Ayasori Rai or Defika Padukon or whatever, Manipur me Bala or Soma or whatever. So now we have this eyebrow lifting, acne scar is done with the help of MNRF, and you see one bluish tint, that is with mono thread. Mono thread subcision, we are breaking the fibers, abdominal stress marks. Abdominal stress mark, okay, this is subcision for the abdominal stress marks. This is picture is from Dr. Amita's clinic. Amita, I need this one. Recent picture for this. This is I have taken immediately, this immediate picture. It was done in her clinic. We do labial peel. So many women come to us because of the darkening of the skin of the labia. Okay. Okay, this also we do 40, 48, 46, 48 to 34, 36, 39. And recently I had a patient. She had this online, our chatting and our online friend. She is actually 51 years old, but she bluffed. Okay, I am 25 and I am a virgin. She already 3-4 times married. Virgin so and so she typed and some picture, our beautified picture sent. The guy really fell for her. He was coming to Manipur. She came running to me. Savannah, first of all you have to give me a proper hymen and I have to look 25. I said, okay, give me so much money. I will not disclose public forum. But she came, I gave her a full with a 25-year-old look, including the hymen. And this is for the subseason for the under eye puffiness. We get very good result. This is one thing I'm happy with the RF subseason and MNRF, because under eye puffiness is one thing, cosmetic thing, which is very, very difficult to remove, but permanent removal without surgery, with RF surgeon we get. Okay, these are the melasma. I'm getting very good result for melasma. Okay, the double chin reduction. This is permanent reduction with radio frequency assisted liposuction. Okay, this is, somebody wanted, there's a man we wanted permanent lip coloring. Why not? I do it. Then said, ma'am, I want a mole. I said, of course I'll give you the mole. Why not mole? I give dimple also. The other day I was operating a patient with dimple. Sir, I think he's not here in his clinic on the OT. So sir asked, Savannah, what are you doing? I said, Sharam, I'm giving dimple. So however much you earn from the vaginal delivery, I will earn from 2 minutes of dimpleplasty. One more thing is, one-sided breast-shaking is a very, very common problem here. We rectify it with the help of radio frequency and this one, thread lifting. Future. Again, I'm coming to future. Only 3 more slides. This is third-degree UV prolapse. By the definition of cosmetic gynae, we are not supposed to touch third-degree UV prolapse, which this one, energy-based devices. She is a lady from an interior area. She is only about 34 years old. So she had gone everywhere and everybody advised operation, either hysterectomy or sling or whatever. Number one, she did not have money. Number two, she did not want to do. She came to me. I did not want, I should have put a video. I did it in one sitting only. So she actually cried. She became so emotional. She had gone everywhere. She said, maybe it's our something of midwifery. They said, you use towel and push it inside the vagina. Imagine she was pushing it inside the vagina, the small towel. So this is only first sitting. I plan to rectify fully in the second and third sitting. Again, this is the future. Again, this is the future in the sense that when we are doing cosmetic and regenerative gynae procedures, we are not supposed to touch third degree. Only one more this thing. Third degree UV prolapse. Now, the future. I am actually really scared of the future of cosmetic gynae. Somebody sent me a video with this radio frequency. She is using condom. I do not know. See, there are so many cosmetic gynecologists all over the country. There are so many trainings. At least basic this thing about radio frequency should be taught to the candidates. She is using this one condom for that. One more thing is here. Can I have 2 more minutes? Lastly, again one more thing here is this lady was having painful sexual intercourse. Is this one her complaint? So this cosmetic gynecologist did everything, energy-based devices, so many things, still not cured. She called me up. I had visited her clinic somewhere in Haryana. So when I examined, there is a cut. There is a cut here. So because I said, do you feel, the one thing I asked is like, is it after peeing? The pain, is it more? So this cut, they did not even have a look. The moment they come with this female sexual dysfunction, any sort of sexual dysfunction, we just tend to insert one machine. Energy-based devices is not a magic wand where we can just insert and treat everything. At least examine the patient. Then this is another one. This one is another one. She was having lots of problem. So our cosmetic gynecologist did everything. The moment I saw this, did anyone make out anything? This is a urethra, this is not the vaginal canal. I saw the cut. I took her aside. Then husband was forcing in the urethral meatus. Just imagine what she is going through, and our cosmetic gynecologist is pushing all energy-based devices in the vagina. We have to be careful about the future cosmetic gynecologists and whether cosmetic I need volume. This is a very renowned senior medical officer. She has given me permission to post this openly. Cosmetic gynae is really high for the truth. She is giving testimonials saying that she came to me and her where is the volume? Bulbovaginal atrophy and all the symptoms had gone completely after coming to me. Counseling is a very, very important part. Training, we conduct training. Plastic surgeons, endoscopic doctors, dermatologists had come to me for training. Nepal, India, everywhere. Also, this is my franchises. It's nice to see me, my photo like getting somewhere in some part of Manipur, in India. This is Dr. Amita here. Nepal have opened first international franchisee trainings here, and I conduct 1 year fellowship also we have added, and other mentorship programs. Conclusion. 360-degree solution or aesthetic cosmetic gynecology is just not a few sets of procedures. We feel that cosmetic gyne is nothing. You go insert, tighten the vagina, that's it. We deal with functional issues, we deal with regenerative issues, we deal with the mental issues, we deal with the social issues. Aesthetic and the cosmetic gyne future is, we have a very, very vast scope, but we need to use, I need a volume now. Audio. This is the last slide. Can't give, it's okay. It's a nice audio. Can you give the audio? Cosmetic gyne, people think very shallow of cosmetic. Now we are no longer using the word cosmetic. It's a aesthetic and a regenerative gynecology, but the term got stuck. This I am still using for the presentation. It is something which we do, complete health care for the woman. Can you give the volume? Increase.
That was a very, very interesting and excellent presentation. I think the audience would want to ask you many, many things. So the topic is open for discussion. For any queries?
Usually I'm bombarded with many questions, so I'm sure they understood, you people and audience, our respected audience understood everything or did not understand anything. Half understanding always, questions always come.
Yeah, this time I think you have explained everything nicely, so they have understood everything. And I hope, I'm very happy that you are from here, you are the pioneer, you are the only one, no need to introduction, as Dr. Subodha has said. You have done so many good things for the society, and you are training the doctors also. So an excellent work, excellent presentation. All the best for your future. Thank you very much for excellent presentation.
If the audience has any question, we can take a couple of questions. So if there are no more questions, I compliment Dr. Savna on your works. You keep amazing us with all the procedures, all the work that you have been doing, and you really make us proud. So with these remarks, I conclude the session with permission of my co-chair, Dr. Netajini.
Thank you, ma'am, for your comprehensive and knowledgeable presentation. I would like to request our chairperson to kindly felicitate ma'am. Now that we have gained insights from our speaker, it's time to deepen the conversation with our upcoming panel discussion. For the panel discussion, we have our moderator, Dr. Arun Madhav Barua, Consultant Apollo Fertility Guwahati, Chairperson Northeast IAGE ISAR, and Dr. Aswin Rao, Consultant Reproductive Medicine and Endocrinology, Salem Polyclinic, Salem, Tamil Nadu. They will dwell into the topic cosmetic gynecology. So let's explore the diverse perspective on this upcoming field of gynecology. Requesting our respected moderators to kindly start this session.
You will carry it on because since this being a Yuva conference, I will hand it over to you. Thank you so much for asking us to be here on this very important topic and a very important day itself. I think everybody has been super sensitized by the cosmetic gynecology by Dr. Savannah, and keeping in tune to the theme of the Congress, and also since this is being an Yuva conference, though I was made a moderator, I still feel my Yuva co-moderator will take it over and he will conduct the panel. I'll just be an observer on the audience side and just take the help as and when it's required. Go ahead.
Thank you, sir. Thank you so much, sir. Thank you so much for your kind words and much appreciated, sir. So today morning, I'm in the middle of the cold Imphal. I'm shivering. I'm ready to take a conversation. I mean, it would be nice if we can have a warm conversation, a little more questions from the audience. Again, I would like to welcome Dr. Savannah to the stage as our champion expert. In fact, I would not say expert, I would say a champion expert, because she seems to be everywhere in India and also abroad, and hopefully sometime to challenge other people in the US, Korea and Israel soon. So Dr. Savannah is the founder and CMD of Savannah She Matters Clinic, and she's also the founder and president of Asian Academy of Feminine Aesthetics. I think there are a lot less mentioned here than what she actually needs, and she definitely thoroughly deserves everything and more. And then coming to our panelists, we have Dr. Amita Bharti from Patna. She's the founder and CMD of Reshape Laser and Gynae Clinic Patna, and consultant at Advanced Orthopedic and Maternity Center in Patna. And she's also one of the founder members of Asian Academy of Feminine Aesthetics and one of the first aesthetic surgeons in Bihar. And next onto the stage, I'd like to have Dr. Taruni Bala. Is she there? Yes. Thank you. She's MBBS MS and currently working as a senior resident at RIMS Imphal. Next, I would like to have Dr. Sushila. She's an assistant professor and Department of Obstetrics and Gynecology, RIMS Imphal, alumni Lady Harding Medical College Delhi, resident LHMC Delhi, fellowship in Advanced Minimal Access Surgery and Robotic Surgery Gurgaon, diploma in Urogynecology, trained in Advanced ART Delhi, trained in USG Obs in Gynecology, member of multiple organizations, and special interest in fetal medicine, laparoscopy, and reproductive medicine. Just a small thing. How come we have not had gynec oncology on this list? That's the only thing pending on this list, I think. Probably, hopefully soon again. That next time when we meet, we'll have that as well. And next, I'd like to invite Dr. Ranjita. She's a member of FOGSI and IOGS, worked in Army Medical Corps as a graded specialist. She's also a senior resident at RIMS Imphal, present multiple papers at RCOG World Congress and her first best 50 in BJOG Supplementary Journal. And she's present multiple talks at the annual conference of Indian Medical Association Manipur State Branch. And next, I would invite the lovely Dr. Alexandra to stage. And today, we're happy to say that it's her birthday today and wish you a very happy birthday. And she's MBBS MS, works as a senior resident at JNIMS Imphal, and currently working as a specialist medical officer at CMC Manipur. Okay, so coming to cosmetic gynecology, I think the previous session was so informative. I think everything has been mentioned in the previous session. So I would like to put for the question more to the panelists, and the ones and later on transfer to the expert as and when required. So this is the panelists. This is going to be an open panel question to anybody who's willing to answer the question. What exactly is cosmetic gynecology? And what are the procedures included in cosmetic? First, we'll take the definition or an explanation, and then go ahead. Yes.
Cosmetic gynecology is a newly evolving subspecialty of gynae. It deals with the aesthetic as well as the functional aspect of the internal genitalia and the intimate parts of a woman. And it has, in recent years, I think there are more focus not just on the treating diseases and all, on basically the quality of life for the women. So I think it is a very newly evolving branch, and it takes aspects from dermatology and plastic surgery, and we incorporate it into our gynecology.
Yes.
And
anybody else want to comment on this further?
More precise, it is a set of procedures to enhance the look and functionality of the sexual function of a woman.
Anybody else? And procedures?
It is a mixed branch. It consists of gynecology, urogynae, plastic surgery, and includes physiotherapy also.
Yes, and anybody would like to take about procedures as to what you have in mind, anything you want to mention? We will go on further with this, but still just a small intro to our audience before we start.
Two types of procedures are usually done. One is non-surgical. Mainly we use energy-based devices in non-surgical and surgical. In surgery, we are usually doing clitoral hood reduction, hoodectomy, labiaplasty, hymen repair or hymenoplasty, and vaginoplasty.
Again, cosmetic gynecology actually emerged more because at one side, because women wanted to look prettier down there, and there's a lot of focus on the word uni these days. Uni is actually the vagina and around the vagina, so the more focus goes to uni, and now there's so much more in even in psychology when people say, look at a uni and admire it. That's what people want. So again, with men being crazy about it before, now we're finally having women being crazy about how they look below there. Again. So our next question here, this is just a basic definition, just to give an idea. A new subspecialty that blends plastic surgery and gynecology and cosmetic gynecology, along with intimate aesthetic surgery in a group of procedures. They are basically cosmetic nature and not medically necessary, but I would like to add a small word there, but we try to achieve functional requirements. So functionally, if you can do something about what the woman is facing, you have a successful practice there. Again, what are the energy-based devices used in cosmetic gynecology?
you have radio frequency, laser, HIFEM, and HIFU.
Thank you, Dr. Dharani. So these are the four major specialty, I would say. I wouldn't say only. There are a lot more beyond it. And we are going to talk about lasers, radio frequency, HIFU, and HIFEM in this topic. So because of time constraint, I think we'll stick to these four. And our next question, what is radio frequency and how does it work?
Radio frequency is an electromagnetic wave, and it functions by tissue contact, thereby creating kinetic energy, which is again converted to thermal energy, causing controlled tissue damage, which in turn causes collagen remodeling.
Okay. And next, how does it work? Who would like to take it? So basically this?
When there is collagen remodeling, there is a new collagen and elastin formation, thereby causing the tissue to become more firm and youthful looking.
Exactly. And so in layman terms, what I would say is all of us have wrinkles on our shirts. And especially our lovely ladies here who wear saris, who like to pleat it up nicely, multiple folds, but they want it to be wrinkle free. So what do you guys do? First thing is you try to iron it out, then you starch it. That's exactly what you're doing in the human body. This is what radio frequency actually does. So radio frequency is a measurement representing oscillative rate of electromagnetic radiation spectrum or electromagnetic radio waves from frequency ranging from 300 gigahertz to as low as 9 gigahertz. And as Madam rightly said in a previous talk, the optimal radio frequency that we really want to achieve during our treatment is around 1 megahertz. So, and what are the type of radio frequencies, if anybody could tell us? Anybody?
Monopolar and bipolar.
Yes, these are common frequently used radio frequency, and as Madam told us before, unipolar is again patented by Alma, so we wouldn't be talking about patented devices here. Yes, multipolar and focused RF, the other things, but we mentioned on a slide as well. Thank you. So next, this is how radio frequency basically works. It basically heats up the skin and mucosa and promotes 3 different kinds of effect. Immediate contraction of collagen, immediate collagen remodeling and elasticity, and long-term stimulation of production of new collagen. And thank you, Dr. Arun, for the wonderful thing. Thank you. And to Dr. Amita, the next question. What is TTRFD?
TTRFD stands for Transcutaneous Temperature Control Radio Frequency Device.
Thank you. It sounds to be a very difficult long 5 letters and all extensively. Would you care to mention a few points as to what you actually think, what you actually mean by TTRFD?
It is a unique combination of radio frequency generator along with a feedback machine that gives a feedback to for energy output to the radio frequency generator. This feedback mechanism is inbuilt in the treatment probe, which is in direct contact of the tissue, and this type of arrangement prevents overheating of the tissue and maintains the temperature in between therapeutic range.
Thank you. What Dr. Amita actually said in simple terms is that we somehow, once we Google or we ask representatives, we find costs ranging from 1 lakh to up to 80 lakhs. Why for the same device? Why does one device cost 1 lakh, and why does the same device with the same kind of function, same outcome results, why does it cost 80 lakhs? Basically a thermostat inside which controls the temperature of the device to prevent it from going beyond a particular set number, to prevent burns basically. That is the most important thing in the particular device, and that's the reason you have a huge price range of multiple devices. If the thermostat works well, your radio frequency work is a real success. So TTRFD, Transcutaneous Temperature Control Radio Frequency Device. So next, I think all of us have been watching Star Wars. I think it's been there from before I was born, after I was born, and now once my son is born, there's still more of Star Wars coming in these days. And I've tried to put up a female Jedi, because my next question would be, what is laser?
Laser, as
Ranjita.
usual, the definition is the same. It's light amplification by stimulated emission of radiation. It also acts just the same way as radio frequency by collagen remodeling.
Thank you, Dr. Ranjita. So basically lasers, all of us have been so used to watching Star Wars. You see so many people swinging it around, killing people, sticking it, and initially eye lasers. Lasers are being used nowadays for every part of the body. There's no part of the body where you cannot use a laser. Initially we thought, okay, inside the oral cavity, no. Now there's laser tonsillectomy, and from below, inside vagina, oh my god, what if we burn something? My husband's going to kill me. No, but look, lasers is there everywhere, and they're definitely going to stay. And with the future of AI, I think laser is definitely there to stay. And light amplification by stimulated emission of radiation is what laser stands for. And our next question to Dr. Sushila, what are the uses of laser in cosmetic gynecology?
Laser can be used for vaginal rejuvenation, it can be used for vaginal tightening, and it can be used for labioplasty. Basically, it increases, generates thermal effect on the dermis, and it can cause collagen rejuvenation, and it can also be used to treat SUI nowadays, and it can be also used for atrophic vaginitis and GSM, that is genital urinary syndromes of menopause.
Thank you, Dr. Mishra. And now if you look at it like, okay, the most important thing that ma'am stressed on again and again during her talk is the exorbitant cost. But here with lasers, one benefit here with lasers is that you can use it for multiple modalities. The plastic surgeon can use it, the dental surgeon can use it, the colorectal surgeon can use it, the ENT surgeon can use it. So when so many people can use it, you can be one of these silent partners who can also use lasers and bring it into your armamentarium. So the actual thing is, it's not so expensive or not so heavy on your pockets nowadays, because if you are working in an institute or a multi-specialty hospital as big as RIMS, I think one laser machine scheduled for different days, I think it's going to cost nothing for your patients there. Again, and what are our type of lasers? Dr. Ranjita.
It can be ablative or non-ablative. And non-ablative includes all erbium yak and neodymium yak, and carbon dioxide fractionated is ablative.
Okay, so this small change we'll have here is that we have ablative and non-ablative. Ablative basically means you make a hole, you make an entry, you penetrate the skin. And non-ablative is something which you just heat up the skin to achieve the desired relief what you want. And on the right, if you see, we have a small picture of how ablative things are. The first one there is NdAg, and the next one is ER/SSG and CO2. So all these work at different levels to work at different parts of the skin or mucosa to give desired results. And next question I have here is, what is HIFU? Dr. Sushila, please.
HIFU stands for high intensity focus ultrasound. In this we use a concave transducer, and then the ultrasound waves are focused into a focal point, and this creates a thermal effect on the thermis, and this increases the temperature, and this causes release of lot of heat shock proteins, and this causes neocollagen synthesis, and which helps in rejuvenation effect.
Wonderful, Dr. Thank you. So, my next question to you again. HIFU basically is high intensity focused ultrasound. My next question to you again, what do you think is the main advantage of HIFU over the other energy based devices?
HIFU is very cost effective compared to other energy devices, and it basically does a very simple OPD procedure. It has the patient has no downtime. She can resume her sexual activities or any other activities at the end of the day, and we don't need high setup, no operative related complications, no anesthesia, and complications are less. So it is one of the most convenient energy devices around.
Yes, thank you, Dr. Sheila. What she actually means to say is it's a tea break procedure. Coffee break, tea break, your boss gives you 1 hour time, go get a procedure done, come back. Morning, you've had intercourse with your husband, evening the husband tells you, wow, what have you done? There's a huge difference to what you have done. And how come you've not even taken time off, you've not taken a break, you've not traveled anywhere, but morning, something else, evening, wow, you're a bomb. That's what HIFU does. It does it to you in a span of 1 or 2 hours. The downtime, only back for HIFU is it, you need recurrent sittings of it. And over a long time, once your pregnant muscles are much stronger, you just probably need memory sittings. And next, Dr. Alexandra, what is HIFEM and what is the mechanism of action?
HIFEM is high intensity focused electromagnetic waves, and the mechanism of action is it uses supraoptimal electromagnetic waves for the vaginal rejuvenation, and it uses around 10,000 Kegels in 30 minutes.
So this is actually a truly non-invasive. In fact, the patient just sits on a chair, like how you see in the pictures there. Sit, half an hour, done. Watch a small documentary or a video, or even play a small game. For example, I've heard that PUBG takes hardly half an hour for a particular thing, so it can be used for anybody. Games this thing, finish off. By the time you're done with the game or the documentary or the movie, your procedure is already done. So this is truly a coffee break procedure. Dr. Amita, what are the surgical procedures that you see in cosmetic gynecology? Again, these are all repeated questions because ma'am has thoroughly covered everything in a slide, so it's just going to be a small memory session. Thank you.
Few surgical procedures which we are doing in cosmetic gynae are clitoral hoodectomy or hood reduction, labiaplasty, vaginoplasty, and hymen repair.
To add to Dr. Amita's answer, I would even say I think every gynecologist that we see here is actually a cosmetic gynecology, because if you look at it, if you have something, if you're doing a PFR is actually a cosmetic gynec procedure, but since it stands under urogynecology, and cosmetic gynecology is actually a branch of urogynecology, even basic PFR, I think everybody in the hall right here, all gynecologists here are actually cosmetic gynecologists. You just need to broaden your focus a little more, and then you're all cosmetic gynecologists.
Can I just add one line?
Yes, no, please.
For this one, all the gynecologists, even we had been doing our PFR in the posterior colpoperitography So when they say that cosmetic gynecology is just something which has been dropped from the sky, no, we had been doing it, we are just giving a different name. But other edit in that. At the moment I am using Aptos thread. Aptos thread I use it in the posterior vaginal wall. So without doing any surgery, without doing any cutting, I am reducing both the length and the breadth of the posterior vaginal wall by actually using the Aptos thread. And also there are other added these things. So, but actually what you said is right. Cosmetic gynae is what we have been doing, all the gynecologists have been doing only, we are just giving a different thing. But Aptos thread is a new one, even for me I have added recently.
Thank you. Yes. Okay. The next question directed to Dr. Alexandra. What is vaginal laxity score?
First of all, what is vaginal laxity? Vaginal laxity means looseness of the vagina. So the scoring can be done through a lot different procedures. One is this Mill-Heisner vaginal laxity score, where you give the patient, let them score it according to how, according to this, they give from 1 to 7. So you can see it in the slide. And one more is ICIQ vaginal VS, that is International Consultation for Incontinence Questionnaire. So in that we give around 14 questionnaires for both the partners, in which 9 of them are for vaginal symptoms, 4 of them are for sexual function, and 1 of them is for quality of life. And all the questionnaires, they have to grade it from 1 to 5, and later on we give add all the scores and we see the symptoms. So the greater the score, the more severe the symptoms.
Thank you, Dr. Alexandra. There's one more thing that she would actually say is that the scoring is done having the husband and wife in mind. It's actually a couple counseling session basically, because laxity is something which is very, very subjective, and it's about where you can reach a sweet spot when they have intercourse. That's what we're trying to achieve with all these therapeutic devices.
I'm sorry to interrupt. These today there some client are cancelled, reschedule, etc. And ICOG session is also Dr. Lakshmi is ready online. So I think we need to wind up at least 3 to 4 minutes.
Sure.
Please.
In 3 minutes.
Okay. Yeah. Winding up time will give you.
Last few questions.
Yes, please.
And next with sexual satisfaction score. I think this is actually again to Dr. Alexandra, but we'll just keep it on the scale. So Dr. Alexandra can just mention those points.
So in this Mill-Heisner sexual satisfaction scale, in which both the partners, the male and the female, can grade it. Number 1 is none, number 2 grade is poor, fair, and the 4th is good, 5th is very good, and 6th is excellent. So both the partners can scale according to that. And after each, before each session, we give this scaling so that we can decide on what the how many next settings we are supposed to do for the patient.
Thank you. So, and again, this question I'll leave it to Dr. Savannah, or who would like to take it. We'll just be quick. So, few small points. It's already on the list.
For indications for HIFM is vaginal laxity, and sexual dysfunctions, and stress urinary incontinence.
Thank you. So, okay. So, our contraindications. Who would like to take this?
Contraindications, patients who are having malignancy are of course a contraindication. Patients who are taking any, who has any active infection or inflammations, they are contraindicated. And patients who are on anti-inflammatory drugs like steroids or any other immunosuppressants, those are contraindicated. And any women who are pregnant or willing to be pregnant in the recent futures, they also should not go for such procedures.
One more point is that we don't want to take up women with over expectations, because that's a real contract, because they're never happy with what you do. So, and next, what is the operating and anesthesia setup? Actually, I'll take this question and give it up to finish it quickly. Basically, you don't need any session, because basically this is going to be...
Dr. Swain, we have to go online, Dr. ICOG session. Okay,
yes.
We'll continue the panel after this also. Okay.
Sure.
So you give the take home message to line take.
So basically what I would like to say is, see, cosmetic gynecologists are there all over the place. every gynecologist who's dealing with the, I mean, if you're a gynecologist dealing with the vulva and vagina, you are also a cosmetic gynecologist. Because every one of you, when you do an episiotomy, when you suture an episiotomy, you try as far as possible bring it back to what it was before the episiotomy. So this is actually a basic for cosmetic gynecology. The only thing we're elaborating over here is to talk about the newer energy devices, which have already been discussed by Dr. Savana in her talk. Again, thank you everyone for the wonderful opportunity. I thank you all my panelists for all your prompt answers and questions as well. Thank you again. And my special thanks to Dr. Arun Verba for giving me this opportunity. Thank you.
Thank you. Excellent panel. Actually, I was not required here. Thank you.
Thank you.
Thank you everyone. The session was full of enthusiasm and valuable knowledge. I request our respected moderator sir and ma'am to kindly felicitate our panelists. All the panelists to kindly come up on the stage.
For the next session, I'll request Madam Netajini to be the chairperson and Sir Tomba. Right there. For the next session, we have a talk by Dr. Saraswati Sanyal Chaudhary from Guwahati. I request Dr. K.H. Tomba Singh to be the chairperson and Dr. T.H. Netajini Madam to be the chairperson.
Okay, now we are continuing the session right now. Dr. Professor Sarwati Sanjan Chaudhuri. He is the professor in Department of Obstetrics Guwahati Medical College. She was the chairperson Medical Education Committee 2013 to 15, Vice President ISOPAR 22, President ISOPAR Assam Chapter, past President of Guwahati Obstetrics and Gynecology Society, member of the editorial board in New Indian Journal of Obstetrics and Gynecology. So, Professor Saraswati Sanyal will be speaking on optimizing fetal and perinatal outcome in diabetes mellitus. Professor Sanyal, please.
Good morning, everyone. I'm thankful to the organizer for giving me the opportunity to speak on this particular subject. I'm especially thankful to Dr. Pratima and Dr. Helen for inviting me to this place. So actually, I have given my presentation to this place yesterday, but I'm sorry that I had to reload it again. So actually, this is a very important problem, the diabetes mellitus in pregnancy. So for that, if you have something, not panel discussion, it's diabetes. It's written in Imphal, yeah. So my topic is optimizing fetal and maternal outcome in diabetes mellitus. So can you switch it over? Okay, if you see this diabetes mellitus in 1900, they found it that it was associated with horrific morbidity and mortality both for the mother and the fetus. Now, if it is an over diabetes mellitus, it has a very serious complication to the both embryo, fetus as well as to the mother. And more the advanced stage of the diabetes is there, which is according to the White's classification, it is inversely related to the pregnancy outcome. That is, it has implications on the complications of the baby in the form of cardiovascular system and renal involvement when the mother has this cardiovascular system and renal involvement. So, it is not going. Can you change this? No. Okay. Thank you. So when you're giving the antenatal care, you need to have the multidisciplinary clinic by involving the endocrinologist, fetal medicine, nutritionist, diabetic care and education specialist. We need to have the standard antenatal care, whatever you are giving. Folic acid is very, very important to reduce the incidence of the malformations, and potassium iodide is also to be given. And both for type 1 and type 2, you have to do the counseling for the risk of development. And if the patient has retinopathy, please remember that it progresses during pregnancy. Other complications, they do not progress in pregnancy, but retinopathy progress. So you need to monitor that in the first trimester and every trimester and 1 year postpartum. Now, lifestyle modifications, all of us know that you have to do, and diabetes specific testing like A1C, creatinine, albumin, and of course you have to stop all those antihypertensive which is usually given. So all of us know that what are the fetal risks, and I don't think I have to give this August so fetal effect. Now, if you see in diabetes mellitus, there is a 25% chance of abortion. And if the level of A1C is more than 12% or fasting blood sugar level is 120 milligram per deciliter, then there is an elevated risk of abortion. And it has been seen that if the woman has a glucose kinase gene mutation, they are more likely to characterize by hyperglycemic variability, and it is difficult to control that. Now, preterm labor, we have seen that it is 26% it is found in diabetes mellitus in comparison to 6.8% in normal. But out of this, 60% is actually indicated preterm labor. Now, the malformation incidence in type 1, you have 11%, and it accounts for half of the fetal death. Cardiovascular malformation is more than half, and if you have isolated chances of having isolated cardiac defect is also 5 times higher. And of course, a specific type of complication that we have is a caudal regression syndrome. Now, there are 3 interrelated molecular chain reaction which causes alteration of the cellular lipid metabolites and there is excess production of superoxide radical, which causes activated programmed cell death that is responsible for these malformations. Now, if the A1C level is less than 6%, the chances of malformation becomes 2.8%. And if it is more than 8% A1C, then the chances of malformation is around 15.8%. So please remember, the chances of malformation is not high, not 100%. So it is not an indication for termination of pregnancy. And I have done continuation of pregnancy with a hemoglobin A1C level with 10% as well. The fetal growth, if you have a malformed baby, it is a less growth. And in case of advanced maternal vascular involvement, there is substrate deprivation, and which causes less fetal growth. But of course, the rule is overgrowth because of hyperglycemia leading to hyperinsulinemia, which causes excess growth of most fetal organs except brain. In type 1, you have 31% macrosomia. In type 2, we have 28%. And in GDM, we have around 24%. The chances of fetal demise in late third trimester or before labor is 3 times in diabetes mellitus, but if it is complicated with preeclampsia, it becomes 7 times. So as a whole, the 3-4 times high because of the poor glycemic control, especially it can be DKA or preeclampsia or placental insufficiency, and 2/3 of this because of the suboptimal glycemic control. And this causes elevated lactic acid in fetus. Umbilical vein blood pH is lower and significantly related to fetal insulin level. And all of us is well aware of the Pedersen hypothesis, which is hyperglycemia mediated chronic aberration of oxygen fetal metabolic transport is responsible for this fetal demise. So neonatal complications are RDS, hypoglycemia, hypocalcemia, hyperbilirubinemia, polycythemia. And there is also, it is related to cardiomyopathy of the neonatal period, which is hypertrophic cardiomyopathy in the interventricular septum, and that leads to obstructive cardiac failure. And it is said that it has to be done a fetal echo in the first trimester, in the third trimester, to look for the interventricular septum and also to look for the right ventricular wall thickness. But the good thing is that it usually resolutes after delivery. And these are the maternal complications, and one of the important complications is preeclampsia. And as I said, if there is diabetic retinopathy in type 1 DM in 2/3 in the first trimester, and the retinal changes occurs in the first trimester, 1/4 will progress. In type 2, the 14% there is chance it can progress. In type 1, there is a risk of hypertension, respiratory complications and depression, and the chances of preeclampsia is highest. The relative risk is around 3.7, so 3 to 4 times in overt cases, and diabetes with chronic hypertension has 12 times more chance. And nephropathy, 5% may have a diabetic nephropathy, and out of them 40% with preeclampsia, but diabetic nephropathy, it doesn't progress with pregnancy. Then neuropathy, the diabetic patient, they also have to have diabetic gastropathy, and that gives rise to troublesome nausea, vomiting, nutritional problem, difficult glucose control, and high risk of morbidity and poor perinatal outcome. And we are very aware of the infections and ketoacidosis. So the goal of management is to eliminate the risk to the fetus, improve the quality of life in mother to prevent short-term maternofetal complications. The role of ultrasound, dating scan is very important, and of course early anomaly scan and the later second trimester anomaly scan, and it is very important that you should go for a fetal echo around 22 to 24 weeks, and especially if the patient is on insulin and with erratic control of the blood sugar. Then early growth scan at 28 weeks, repeat growth scan at 34 weeks. You have to put it in growth charts, color Doppler, and that you can see for the the uterine artery and other things to rule out that the chances of preeclampsia is there or not. The targets, glycemic targets, is fasting should be 95, 1 hour is 140, and 2 hour is 120. All of us know that. And with the principle of medical nutrition therapy, which is the first line of management in case of GDM, there's optimal nutrition for maternal fetal health. You have to give adequate energy for appropriate gestational weight gain, but it is very important to achieve the normoglycemia. The weight gain targets is according to the normal weight, it is from 11.5 to 16 kg, but if the patient happens to be a high BMI, and we can reduce it to 5 to 9 kg. The calorie requirement, too much of hypocaloric diet also can lead to ketonemia and ketonuria, and moderate caloric restrictions in obese women in GDM may improve the glycemic control without ketonemia and reduce maternal weight gain. So our advice to the patient will be, depending on the standard care, that small gap between the 3 major meals, 3 minor meals, include fiber, includes whole fruit instead of fruit juice. Now, the next drug comes is one of the oral hypoglycemic agent, is the most studied drug is metformin, and MIG trial has established its effectiveness, and it improves insulin sensitivity and does not cause hypoglycemia. And it is preferred because administration, and it has a reduced weight gain and less chance of hypoglycemia. Next OHA is glyburide, which is a significant placental transfer occurs, and cord maternal plasma ratio is 0.7 at delivery, and safe up to 10 milligram BD, and the risk of teratogenicity is not proven, but we do not use that glyburide. And the most studied drug is insulin, and directly we go to the insulin if the postprandial sugar is more than 200, and starting dose starts from 8 units, and the dose is to be adjusted on follow-up, and at the same time MNT also has to be followed, and the frequency of monitoring be decided by the treating physician gynecologist. If the pregnant woman requires more than 20 units per day, she should be referred to higher healthcare center. SMBG, this is very, very important part of the management. So you need an educator how to do it, and it can be easily done, and the domiciliary management also can be done. Now this is new thing that has come, is the continuous glucose monitoring, which helps to achieve target of hemoglobin A1C, but not to substitute SMBG. And real-time CGM can reduce macrosomia, neonatal hypoglycemia, and type 1 DM. A rapid reduction of insulin requirement indicates placental insufficiency. So this is very important. In the last part of the pregnancy, if suddenly the requirement of insulin is coming down, you have to think that probably placenta has not been properly functioning. And of course, telehealth plays a very important role. Now there are 41 studies regarding the efficacy of metformin, glyburide, and insulin in 7,000 women, and they have compared this metformin, insulin, and the insulin had significant increased risk of preeclampsia, NICU admission, and neonatal hypoglycemia, as well as macrosomia. The metformin, Cochrane suggested the risk of GDM reduced by lifestyle, diet, exercise in the first and early second trimester. But meta-analysis of 11 RCT, they said the metformin does not reduce the risk of GDM in obese and PCOS. So if you want to give us metformin as a preventive for GDM, usually that does not help. Then if the patient has metformin because of the diabetes, oral, there's a low risk of hypoglycemia, less weight gain. There's a study, MIG-TOFU, which says 7 to 9 years older, higher waist and height ratio. Where the baby is followed up to 7 to 9 years, they have a higher waist to height ratio, waist circumference, than those of insulin. And recent meta-analysis has showed you get smaller neonate, accumulation of fat in the postnatal growth, higher BMI in childhood in comparison to insulin. Then it is a comparative study we have done. We have given 104 cases, open label, metformin in one group, insulin in other group. And the results we have seen that mean weight gain was significantly higher in case of insulin, and large for date is found in case of insulin, which is a very significant. So metformin not to be used in women with hypertension and preeclampsia, as there is already a risk of fetal growth restriction, and metformin also causes lesser growth of the fetus. Then potential for growth restriction or acidosis in the setting of placental insufficiency. So when to deliver? Varies with glycemic control, avoid postdatism, too early causes prematurity, too late macrosomia, wait for spontaneous labor in well-controlled cases. So FIGO has said at 30 to 39 weeks, if the weight of the fetus is less than 3.8 kg, for us I take as 3.5 kg, no history of stillbirth, vascular disease or poor control or compliance, then deliver at 40 weeks. But if the baby is more than 3.8 kg, then you induce at 38 to 39 weeks, and the baby is more than that and weight is more than 4 kg, we'll always offer a primary cesarean section. And intense monitoring at the time of labor, we all of us know that half dose insulin and all this we are doing on a regular interval. Labor management, controlled ARM should be done, anticipate shoulder dystocia, active management of third stage, have to have a neonatologist, prepare for postpartum hemorrhage, NICU, early cord cramping, and be prepared to tackle neonatal hypoglycemia. The postpartum care, insulin you have to reduce half. And first 48 hours, we do not give. If we do cesarean section, we just wait the patient to be on normal diet and then we titrate this. And for GDM, screening at 4 to 12 weeks with DIPSI, lifelong screening every 1 to 3 years. You have to do lifestyle intervention. Long-acting LARC is important for them for contraception, and psychosocial management. Thank you so much for a patient hearing. I think I'm on time. Yeah.
Thank you, Dr. Saswati. That was a very nice presentation of a very important subject. Now the topic is open for discussion. Any questions from the audience?
I don't think there is time because SAFOGSI is waiting.
Okay. So, I feel very privileged and proud to share the chair with my teacher and guide, Professor K.T. Singh. I'm so happy today. Thank you, sir. And there was a very nice presentation, so I hand over the mic to my sir.
Thank you, Dr. Sanan, for your nice presentation, and it is a warming one. And whatever we have to ask to you, everything has been you have highlighted. The take-home message also be given towards the end of the thing. But only time what we need is when to deliver the baby. That also you have already highlighted. But only thing, the awareness what we need to give to our patients is this is an alarming condition, so it should be diagnosed right from the early stage, the early first weeks of first trimester of our nurse. From that we can continue managing to avoid all those different risks which you have highlighted. So thank you very much.
Thank you, ma'am, for the comprehensive and knowledgeable presentation. Now I request the chairperson to kindly felicitate the speaker. Next, we'll have the ICOG session, Swasth Nari, Sukhi Nari, a panel discussion on abnormal uterine bleeding. The moderator, Dr. Lakshmi Shrikande, Chairperson ICOG and National Corresponding Editor, JOGI, will be joining us online. And I would like to call the panel expert, Dr. Netajini Thangjam, Professor and Head, Department of Obstetrics and Gynecology, JNIMS, and Professor Rajkumari Praneshwari, Professor OBG, RIMS, and past Secretary IOGS, Dr. K. Pratima, Assistant Professor RIMS and Secretary IOGS, and Dr. M. Ronita, Assistant Professor JNIMS.
Hello. Ma'am, you see us? No. Okay, okay. Madam cannot see us. Okay, just can you, ma'am, can you hear us? Good morning, ma'am. Can you hear us? Ma'am, can you unmute? We cannot, we can see you, ma'am, but we cannot hear you. Yeah, yeah, ma'am. We can, through the mobile too, we are hearing. From this device, you can hear me? Yes, madam, we are able to hear you. From this device, you can. Shall we share the CV? Yes, you can introduce without CV also.
We have here four panelists. Madam R.K. Praneshwari, who is the past secretary of the Imphal Obs and Gynae Society. She is currently serving as the professor in the Regional Institute of Medical Science. And we have Madam Netajini Devi, who is the professor and head of department of the Jennings Institute, Imphal. And we have another Dr. M. Ronita Devi, who is the assistant professor in the Jawaharlal Nehru Institute of Medical Science. And I am Dr. Pratima, who is the secretary of the Imphal Obs and Gynae Society. Ma'am, we have four panelists here.
And without wasting time and straightway sharing my screen so that we can cover up some of the lost time. So this is the panel where we are discussing. Am I audible?
Yes, ma'am, you are audible.
I am audible. I will just share my screen. I just open my Can you all see?
Yes, ma'am, we are able to read.
Yes, so we are discussing the case base. Just to give a brief intro, we all know that abnormal uterine bleeding contributes to 25 to 30% of all our gynecological patients. It causes iron deficiency, anemia, and it also has a negative impact of quality of life. These are all discarded terminologies. We no more use all these terminologies. So what is accepted is AUB, HNB, HPMB for intermenstrual bleeding and PMB. So these are the terminologies which PIGO has recommended, and we have to use these terminologies in our day-to-day practice. And remember, abnormal uterine bleeding is not a diagnosis. It is a symptom or a sign. And how it is defined? It is any variation from the normal menstrual cycle. What is that means? If there is any change in the regularity, any change in the frequency, or any change in the duration of flow, that is abnormal uterine bleeding. It can be acute or it can be chronic. So everyone has to follow this palm point classification in our day-to-day practice. So let us go to the first case. She is a 43-year-old. She has 2 living children. Last child was 15 years back. She has come to you with history of menstrual bleeding, heavy menstrual bleeding since 4 years. She has undergone DNC polypectomy 2 years back. Histopathology, normal. It was proliferative phase. But this HMB recurred after 6 months, and now the repeat USG is showing only 0.5 centimeter. She has taken only pause MF, and now she has come to you. You have examined her. She is showing mild pallor. Per speculum, cervix is enlarged, os is open. You can see small polyp. And when you feel it on PV, it is 1 centimeter. Of course, transvaginal ultrasound is of extended arm. You are doing the ultrasound and you found that uterus is bulky, endometriosis is 8 millimeter, polyp is arising from the uterine cavity with the feeding vessel identified on Doppler. Ovaries are unremarkable. So now these are the points to ponder. Anyone can answer. What are the therapeutic options here? First and foremost, according to palm coin, everybody agrees with me that this is a case of AUB, AUBP. Yes. So now what are the options? Let's discuss. Will you give hormone? You will advise polypectomy without hysteroscope? Will you go for hysteroscopic polypectomy or will you jump to hysterectomy because she has come to you the recurring bout of HMB? Or do you have any other options?
Actually, because of her genetic conditions, we can start the hormonal first with supplementation of the iron, and then we can try polypectomy, hysteroscopy, or with a conventional and hysteroscopic polypectomy we can do. And if it is willing for family completed, and then if she wants hysterectomy, we can do hysterectomy also.
Any other opinion? Because she is AUBP, so ideally she should be subjected to hysteroscopic polypectomy. If this polyp has recurred, it means previously, either it was an incomplete polypectomy or it was not done under hysteroscopic supervision or just a bad luck of the patient that it has recurred. But this time you have to do the complete procedure, so it is better to do a hysteroscopic polypectomy. Friends, FOGSI is all about preserving the uterus. So, how many of you agree that this is really an indication for hysterectomy? I have got 4 panelists, so how many of you agree?
This is not a candidate, and then we have to do first conservative.
Yes, because this is not an indication for, it is a clear-cut case of AUBP, and hysteroscopic polypectomy is the drug of choice.
Yes.
If after doing your complete surgery, she again comes back to you with a bout of HMB, then you have to think of the hormonal treatment, and we are coming to about the LNG IUS, which should be the preferred method of treatment in this case. Now let us come to case O.
Hello, sir.
Comes with frequent heavy bleeding since 6 to 8 months. She wants to undergo hysterectomy in view of the USG report. And what is the USG report? It is uterus is slightly bulky with 2.5 centimeter fibroids in the body of the uterus. Endometrium is 6 are there. Menstrual history 6 to 7 days bleeding. Every 20 to 24 days is the frequency of her cycle. There is no dysmenorrhea, but of course she is having a heavy flow with passing of clots. She has undergone 3 LSCS, bilateral tubal ligation is done. Last C-section was done 10 years back. No history of malignancy in the family or any other major illness in the past. Remember, per speculum examination is a must in all the cases of AUB. So here it is normal. On per vaginal examination, uterus is parous, there is mobility, and now we are discussing the approach to management. So what are your options? Hormones, which hormone? Progesterone ablation, endometrial ablation, hysterectomy on demand. I have put a big question mark. So let us discuss all these options for our audience. So how many of you will start with the hormonal treatment?
We can think of hormonal treatment mainly for cycle regulation, because the size of the fibroid is not significant, only 0.5.
Fibroid size is
0.5 centimeter tube. It is so small.
so small.
I know many of the doctors, they tell that there is tumor in the uterus, you get rid of the uterus.
Yeah,
So
and
again,
then the
I am
endometrial thickness is
emphasizing,
also.
re-emphasizing the FOGSI policy of preserving the uterus. So friend, this is not an indication for hysterectomy.
Yes, ma'am.
How many of you will do? Because she is asking. She herself wants hysterectomy on demand.
We will try to convince her not to undergo hysterectomy. We'll be counseling her regarding the different side effects of hysterectomy. And if at all she insists, then we'll think of ovarian conservation. Supposing
Yes, so
she is
yes,
from a
anybody saying
far-flung
anything?
area,
Yeah.
who's not going to come for further treatment, very difficult for to come for treatment, then as far as practicable, of course, we'll advise her to undergo conservative management only with hormonal therapy. Sometimes we can think of this progesterone IUCD also, and
Yes.
hysterectomy should be the last option.
Correct, correct. So just to summarize for everyone, that the first mode of choice is of course LNG IUS, because here the fibroids are not intracavitary or submucosal. It is not distorting the cavity, uterus is not so big, so there is no contraindication for LNG IUS.
Yes.
But if your patient is reluctant for LNG IUS, you should start with the oral hormonal treatment. If at all you feel, because we say that decision of hysterectomy should be individualized. So if at all you feel that she needs hysterectomy, then definitely combine this with bilateral salpingectomy. I am not saying bilateral oophorectomy. Bilateral salpingectomy should be done in each and every case of hysterectomy. To remove the ovaries or not should be individualized based upon various factors which as a treating clinician you have to take into consideration. Now in this era, patients, they read a lot on Google, so they are having so many queries, rather they are there to teach you. So you should be able to counsel them as far as the risks and benefits of removing the ovaries at the age of 43 years. Remember, she is just 43 years of age. So don't forget that if you remove both the ovaries, she will be a case of premature menopause, where the Indian Menopause Society is definitely recommending the menopausal hormone therapy if you are doing bilateral oophorectomy at the age of 43 years. So you have to again tell the patient about the pros and cons of MHT versus preserving the ovaries. Preserving the ovaries can lead to later on ovarian cyst in rare cases and malignancy in rare cases. So you have to counsel the patient that these are the disadvantages of keeping ovaries versus the advantages of keeping ovaries, where they can avoid HRT. So this was, I was talking about LNG IUS. It is a very good option, especially for those who want a long-term contraception, and LNG IUS gives endometrial protective effect for 8 years. Literature, there is so much literature that it is a very safe, effective option in the treatment of heavy menstrual bleeding. Now let us come to the case that is AUBN. She is a 42-year-old widow. She is complaining of menometrorrhagia. I know this is outdated terminology. She never went for any consultation or checkup. This is her first visit she has come to you. She has 2 full-term normal deliveries. Last delivery was 20 years back. No other vascularity. Workup. Can anyone tell now how you will proceed? Now this is for you all to answer. How you will proceed?
And then first we will work up the blood vessels
Just in the word, yeah. Yes. many of you that for all the cases abnormal, you should do a urine pregnancy test? Yes or no? 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 Hello? How many of you will do a urine pregnancy test? She is a widow, but even then she has come to you with abnormal uterine bleeding, tubal ligation is not done. How many of you will do urine pregnancy test?
In pregnancy case, in any patient who come with in the reproductive age group with bleeding PB, the first thing we rule out is we always rule out pregnancy. Then we always work up what are the other causes.
Very good take-home message. This is the take-home message for all the audience, that whenever any patient comes to you with abnormal uterine bleeding, you have to first do a urine pregnancy test. Sometimes it can be very, very sensitive. You cannot tell her, but you can just do urine pregnancy test in your own. Don't charge her for that, so that you are a peace of mind that you have not misdiagnosed or you have not you have not done something which you should have done. So urine pregnancy test should be done each and every case of abnormal uterine bleeding. Now ultrasound, how many of you agree that it should be done?
Yeah, any patient with a reproductive age group, any patient comes with bleeding, we always do all patients.
Yes. PVS, as I was saying, it is just an extended arm. We do per speculum, per vaginal examination and transvaginal ultrasound in the
in the slide, ma'am.
Whether you will take colposcopy directed biopsy, what you will do?
If the colposcopy directed biopsy, if available, we do, but sometimes here too it is not available in all the facilities like colposcopy directed biopsy. Then sometimes we do BIN or the acid with the acetic acid or with the Lugol's iodine. We do the biopsy. If the colposcopy is not available, and dependingly on the results we get on that, then we have to treat the patient. If it is dysplasia, then we may go for the observation and follow up, and if there is something suspicious of the malignant changes, then we have to treat accordingly, ma'am.
HPV test.
Earlier it was not available here. Only in the private sectors the HPV testing is available, but for the last, even in our institute, the HPV testing is now available free of cost with the project. So we have started doing the HPV testing along with the pap smear.
Great. So remember that you have to rule out the pregnancy and pregnancy related complication. In this case, of course, the cervicitis. You have to be aware about the malignant changes in the cervix, and as I was saying that it was congested and hypervascularity. So you have to treat her as per the cause. If it is PID, treat her with antibiotics and anti-inflammatory drugs. Pregnancy complications, you all are obstetricians, treat her accordingly. If on histopathology you see moderate dysplasia, then you are absolutely right. Observation, it is not an indication for hysterectomy. I know there are many OBGYNs who, on the pretext of dysplasia that you will develop cancer in the future, they themselves are advising hysterectomy in these cases, which is a wrong practice. So hysterectomy is not an indication in these cases. Now let us come to the management of acute episode with severe anemia. This is a 53-year-old, gravida 3. Tubal ligation has been done, comes to you with profuse bleeding since 4 to 5 days. There was history of hypertension since last 4 months and she is on treatment. There is no other major illness. Her previous menstrual history is regular. At present, of course, she is a case of heavy menstrual bleeding. On examination, you see severe pallor, BP is 170, 110. She is bleeding profusely with passing clots and hemoglobin is 4 gram %. Now how you will proceed? She is a case of acute bleeding, hemoglobin 4%, 4 gram and hypertensive.
Hello, ma'am. First, we do the resuscitation and the blood transfusion because then the BP is also high, so we have to control the heart blood pressure. And this thing, when the C is fit for the DNC, then we have to do the endometrial sampling to rule out any malignancy.
Is estrogen available there?
Ma'am? We can't give estrogen.
IV estrogen is available?
No. No available. We can't give she is hypertensive and it's not available here.
To control the bleeding along with your blood transfusion?
We can start after the blood we can after the endometrium biopsy is taken, we can start the oral progesterone, and to control the bleeding we have to give the hemostatic agents, like we can give the tranexamic acid to control the bleeding, acute episodic bleeding.
Contraceptive pill, you can gradually taper it. If she is hypertensive and she is having contraindication for estrogen, you can give her high doses of progesterone, which you can gradually taper it. And yes, you can go for balloon tamponade once she becomes fit for anesthesia. Now just let us discuss a case of postmenopausal bleeding. This is a 74-year-old woman. She is a real case which I have managed, mother of professor, medical college. She has come to me for bleeding per vaginum, 2 such episodes. She is hypertensive, mild diabetic, average BMI. Per speculum, no active bleeding, cervix vagina atrophic, uterus is less than normal size. What is the USG report? Query, because radiologists have done it, query small polyp in the uterine cavity, thickened endometrium. Now can you tell me what is the cutoff of endometrium in cases of postmenopausal bleeding? Yes, anyone? Just tell me the cutoff endometrial thickness in cases of postmenopausal bleeding.
Hello. The answer for this, the level 4 is less than 4, then we have to exclude endometrial biopsy.
Aplasia with or typical cells. So now she came for second opinion. So what you all feel, whether appropriate workup was done before she came to us? What workup would you like to add? This is the only workup, ultrasound, DNC, and now she has come for second opinion because she is worried.
We have to do blood test and a pap smear, and then again a TVAs, transvaginal sonography, and then papillary endometrial cytology, fractional curettes, and hysteroscopy available, targeted with the biopsy of the endometrium.
Few are typical cells. So in this case, you should do targeted biopsy under hysteroscopic control. Don't jump to the hysterectomy, but if at all you are planning to go for hysterectomy, it has to be a planned surgery because she is a case of postmenopausal bleeding. Remember, 90% of postmenopausal bleeding are not malignant causes. Only 10% of postmenopausal bleeding are because of CA endometrium. So this should be known to everyone, but here she came to you with a histopathology report of few atypical cells. That is, according to the new classification, she comes into the WHO category of hyperplasia with atypia. So in these cases, the chances of coexistent malignancy is 40 to 50%. So you have to plan hysterectomy, but you should ideally, ideally you should have the facility of frozen section with you. So intraoperative, you can send the sample for frozen section. Are these facilities available there, Pratima?
Yes, we have got it.
Hello?
We have provision for a frozen section.
Case of malice, and you would like to do a surgery. I have seen patients, they are just taken for hysterectomy, only uterus is removed. If they find any difficulties, they don't do removal of oophorectomy, but nowadays NDVH, where it should be done, definitely it should be done, but this is not a case where you should be doing a non-descent vaginal hysterectomy. If at all you are planning hysterectomy, it has to be either a proper laparoscopic hysterectomy where you can see everything, or if you are not well trained in laparoscopic hysterectomy, this is a fit case to do abdominal hysterectomy with frozen section biopsy, so that you know if she is a case of malignancy. You can remove the ovaries, you can look for the lymph nodes, and you can do a complete surgery in that very setting itself. Now meiosis. Just look at her weight. 41 years, 83 kg, came to you with frequent menses. 2 full-term normal delivery, one was LSCS, tubal ligation done, all routine and thyroid functions normal. She has taken Sevista for 6 months, so menorrhagia got converted into amenorrhea, but she developed cyst in the left ovary. She stopped Sevista, cyst regressed, but menorrhagia got resumed. Now the uterus is 10 cm by 5 cm by 4 cm, adenomyosis, diagnosis is adenomyosis, endometrial thickness is 2.2 cm. Endometrial biopsy done, showed simple hyperplasia, Mirena inserted, bleeding continued, Mirena got spontaneously expelled 8 months after insertion. She is taking Registron off and on her own. On repeat USG, endometrial thickness is 1.2 cm. Now how he will proceed?
We can try with this hemostatic, that is tranexamic acid to start with, and then she was getting progesterone off and on, then Sevista also, which was not effective. Now we can think of thermal ablation of the endometrium. But most of the time, adenomyosis, they do not respond to the drugs and other treatment. Most of the time, we have to do either adenomyomectomy or, but the patient is very young, only 41 years old, so we have to see the pros and cons of the treatment. Either to subject her to hysterectomy.
No, she has complete childbearing, but again this is not an indication for hysterectomy. Now we have got various medical options which are available for the medical management of fibroids and
adenomyosis. Yeah, we can use Dianosis. Hello?
I have there my another device. Hello, can you hear me? Hello, hello. Adenomyomectomy. Hello, hello. Am I? Who wants to have the children? Remember, even we are getting patients who are 41 years age, 45 years age, but they want to have a child. So there we offer them adenomyomectomy, but not in those cases where they have finished the childbearing. So yes, hysterectomy is the last option in these cases where they have finished the childbearing. So we will just discuss one last case of adenomyosis, one more case of adenomyosis before we wind up. So this is the case. She is 42-year-old, para 1. She is having mitral valve prolapse and gross obesity. Look at her weight. She is 130 kg, having polymenorrhagia since 2 years, and she is vitals are stable. USG is showing bulky uterus, adenomyosis, endometrial thickness is 14 millimeter. So now what next? She is a case of heart disease and adenomyosis, AUBA. She is not fit for surgery.
Yeah, as she is not fit for surgery, we will go for conservative, but always we have to rule out malignancy. So we have to do an endometrial biopsy and rule out the malignancy. And if there is no malignancy, we will definitely go the conservative management. That is the other option slide. We can go for Marina or other treatment. Hello.
For major surgery, we took all the informed consent, and she was posted for repeat DNC. Frozen section was done at the same time. It shows only cystic glandular hyperplasia, so she was not having malignancy. Thermal balloon ablation was done, which to our great fortune gave her significant relief, and she is doing well. So remember, you have to sometimes think out of the box, and every case has to be individualized. I know there are various reasons for choosing hysterectomy bleeding, like failure of your medical management, failure after doing repeated DNC, she is not responsive, thermal balloon ablations, or there are some complications to this procedure. Sometimes patient is having poor compliance, they are coming to you from far off places and they can't come to you for the regular follow-up. Then also in these conditions, you have to take the definitive mode of treatment which you have to choose for that patient. So if there is a history of malignancy in the family, that is why we always say it has to be individualized. Now one slide that if it is a polyp, you have to do quick removal. Multiple polypoidal endometrium and fertility is not desired. LNG IUS can be combined with the surgical removal of polyp. That is, after removal of polyp, just insert the LNG IUS. Adenomyosis, first line is LNG IUS. Second line, if LNG IUS is not accepted, you can give GnRH agonist with add-back therapy. Third line therapy is OC pills, NSAIDs and progestogens. If it is a case of fibroids, then the treatment depends on the location of the fibroid, also whether fertility is desired or not. If fertility is desired, the first line therapy for intramural or subcellular myoma is again LNG IUS, tranexamic acid or combined oral contraceptive pills. Second line, where fertility is desired, that is abdominal or laparoscopic myomectomy. If fertile, of course, short-term management, you can give GnRH agonists with add-back therapy followed by myomectomy. Long-term management, now we have LNG-IUS, Bilipristal, 6-Pristone, and now for fibroids, oral GnRH antagonist also available in the India, which is giving good relief. So you can prescribe them oral GnRH antagonist as well. Of course, if it is a case of malignant, then you have to correct. If it is hyperplasia without urticaria, then first line is LNG-IUS and second line is oral progestins. This was the AUB, that is PAM. So how to point etiologies? First line EIUS and tranexamic acid. Second, oral proteins. Third line is, if all these fail, you can give them GnRH agonists with add-back hormone therapy as far as possible. Of course, every case must be evaluated and treatment must be individual, is as per parity of the patient, severity of the bleeding, response to your therapy, socioeconomic strata, a desire for fertility, and also the skill and experience of the treating physicians along with the facility at your place. So thank you so much for participating in this panel discussion. I thank all the esteemed panelists for their valuable inputs, and I thank Pratima for organizing this hybrid mode for
Thank you, ma'am. In spite of the technical difficulties, we've managed to pull through the discussion. I would like to invite Dr. C.H. Nabakanta, sir, to kindly felicitate the panelists.
Now we move on to the last panel discussion of today's scientific session on the topic complicated MTP cases. For this, I would like to request our moderator, Dr. Anuradha Panda, Senior Consultant in Obstetrics and Gynecology, Laparoscopic and Robotic Surgery, Apollo Healthy City, Jubilee Hall, Hyderabad, and Dr. Rajkumari Praneswari, Professor, Department of Obstetrics and Gynecology and Immediate Past Secretary, IOGS. Requesting our moderator to kindly initiate the panel discussion. I would also like to request our panelists, Dr. Amita Gupta, Dr. L. Biswajit, Dr. Vandana, Dr. Manjushree, Dr. Mandakini, Dr. Rukamani, and Dr. Rupavati to kindly come up on the stage.
there is modification in the this one program, because our co-moderator flight reporting is 12, so it has supposed to be panel last, but we have to prepone the panel discussion before that lecture.
We'll go ahead with the panel. Morning, everyone. I think the panelists can give one-line introduction. I think they are putting on the CVs.
Okay, ma'am, I'll take this one.
You can go directly. Yeah. We'll go ahead directly with the panel is. Please
Good morning,
introduce
everyone.
yourself. Yeah.
I am Dr. Amita, and I am a professor and former head Government Medical College, Jammu.
Good afternoon, everyone. I am Dr. Mandakini. I am working as a senior resident in RIMS.
Good morning, everyone. I am Dr. Purarapam Ribhavati Devi. Currently, I am working in RIMS as senior resident.
No.
Good afternoon, everyone. I am Dr. Manjushri Thapam, and currently I am working as consultant in Manipur Health Service.
Good afternoon, everyone. I am Rukamani, senior resident of St. Gynae RIMS.
Good afternoon, everyone. I am Dr. Biswajit, SR RIMS. Thank you.
We'll go ahead with the first case. This is a 29-year-old lady, para 1 L1 abortion 1, came with fever and abdominal pain since 4 days. She had taken treatment for medical abortion at 9 weeks from a practitioner that was around a month back. Ultrasound showed a 35 mm highly vascularized mass in the uterine cavity. What is your diagnosis? Can we start from one end? Yeah.
Since she has taken medical termination of pregnancy at 9 weeks of gestation, and as we all are aware, for recommendation is till 49 days of amenorrhea. So there are already less chances of a medical termination being successful. Then, since she has been bleeding in this case for long, she got infected, superadded infections, and as a result of which there was fever and pain. Then 35 millimeter highly vascularized mass, which obviously means that retained products of conception, they are still active. Even if you go for her pregnancy test, it would be positive. So my diagnosis is retained products of conception superadded with infection. So before I deal with this case, I will definitely go for antibiotics, and then after
We'll
that,
come to that. Next. Yeah, do you need to do ultrasound after giving medical abortion pills?
Yes, ma'am.
When do you do it? When will you do it? In the first, and how many days after giving the tablets will you do?
After 2 weeks, ma'am.
After?
After 2 weeks.
Yes, after 2 weeks when she comes for the checkup, we should always do. Actually, the
ultrasound.
protocol says you can actually do a examination and find if you feel it is incomplete, do. But for safe side is available, always do.
Yes,
and do you routinely give antibiotics in medical abortion? You can go to next one. Yeah.
actually the recommendation is that before giving medical termination, we should have ultrasound before also, so that at least we rule out ectopic.
Yeah, that is done.
Number 2,
That is-
gestational
yes.
age, and number 3, we don't give routinely antibiotics
You
for
do not
medical
give.
termination of pregnancy. It's not
Yes.
recommended.
It is not recommended. The NICE guidelines say that when you think there is high risk of infection or you think she may be screen positive for STD, then you can give. Otherwise don't, unless there is antibiotic resistance. And what is the regimen or drug used?
Ma'am, we can give injectable antibiotic like ceftriaxone.
I don't think we should give
Not
injectable
special.
when you are doing in our clinics and setup. Oral would be better. A 3 day.
Doxycycline, ma'am, we can give.
Yeah, you can give doxycycline, metronidazole, or azithromycin.
Yes,
You
ma'am.
can give either a single or a combination of antibiotics also, depending on your how you feel. And a 3 days course is enough. You need not even give a 7 days course.
Okay, next scenario. Next case, a 35-year-old G2P1L1 with essential hypertension, type 2 diabetes since 2 years, came to OPD with 6 weeks of amenorrhea. She has an AC inhibitor 40 mg once daily for hypertension, and then glyceride 10 mg for diabetes with HbA1c of level of 9. Obstetric history. She has got cesarean section 5 years back, and she had GDM in her last pregnancy. She wants to know whether she can continue her pregnancy.
Ma'am, she is 6-week pregnancy and she is on antihypertensive ACE inhibitor,
Yes.
and her diabetes is also not yet controlled. HbA1c is 9, so better to terminate the pregnancy.
And then how will you counsel? I mean, like if she have to be terminated, then what is your counseling?
We should counsel the patient that she should control her hypertension with safer drugs, and she should control her blood sugar before planning for next pregnancy.
No. In case she said that she is a treated subfertility, I wanted to continue, and what are the counseling you have to give?
Definitely yes, because we have to counsel her. We can't ask her. We can dictate her to go for termination, because even at the hemoglobin level, HbA1c of 10, the chances of malformations in the pregnancy, they are only 30%. You can only tell her the statistics. We cannot take decisions on her part. Number two, she was on ACE inhibitors, which definitely have some effects on the fetal kidney. And for that we have to inform her. But we cannot say that you go for termination.
Correct. Next question.
We go to the third question. This is a 35-year-old lady, Mrs. SR, with 2 previous cesareans, was referred with a 7 weeks of pregnancy with spotting PV and cramps since 2 days. She had history of taking MTP pills by her local physician. A TB scan done by the physician there, before sending, showed a 7-week gestational sac in the lower part of the uterine cavity. Beta HCG is 7000. What is your differential diagnosis first? The sac is in the lower part of the uterine cavity. What will you think? And she had 2 previous cesareans.
So, ma'am, we can think about skirt pregnancy.
Yes, huh? Yeah, yes.
And then differential diagnosis will be, it could be like cervical pregnancy.
Okay, it could be cervical also. Anything else?
And then might be threatened abortion.
Could be. Maybe she's aborting, it has come down to the lower part. It's important that we see the scan which was done before we gave her the tablets. Yes. And she didn't have that scan then. Okay. Now what is your diagnosis with all this?
Ma'am, diagnosis will be like skirt pregnancy.
Yes, okay. We'll come to that. And when you say it's a scar pregnancy, what's the other thing you should do and look in your ultrasound? When you say scar pregnancy, you should have the pregnancy in the lower part, in the niche, and the cervical canal also should be free. Right, and the upper uterine cavity also should be empty. And what's important is the myometrial thickness above the gestational sac, between the gestational sac and the bladder. Even that's important, how you manage it. Okay, the cutoff is 3, less than 3, more than 3. Yeah, we'll come to that. And would it be necessary, last doctor I should ask you, Doctor, yeah. Would it be necessary to fill in the MTP forms in this case?
Ma'am, it is not necessary to fill in the MTP form because he has already taken the MTP pills.
No, if she has taken the scar, I mean, even if she has taken the MTP pills, you may have to fill the form, but in the scar ectopic or a cervical pregnancy or ectopic, you don't need to fill the forms. Okay? Yes. So, we say, so small a mistake, I think this is a different one. And the myometrial thickness is 1.5 mm. How will you manage her? What are the options to be managed?
For cesarean scar pregnancy, we have multiple options of management. Like we can, first one is generally, I'm just talking about general.
Yes, okay.
Expectant management, in which patient is asymptomatic and then pregnancy is by very early stage and beta ICG is in a falling trend. In those cases, I mean,
expectant, actually in a scar pregnancy, we should not be doing expectant management. Yes.
I'm talking about general, ma'am, not
yes.
specifically about this point.
Now tell me about this case. Now
Okay,
this is 7,000, is around 7 weeks. The scar thickness is only 1.5.
Yes, ma'am. In her case, medical management would also not be possible because it's already above 5,000 beta ICG. So we will offer surgical evacuation. Before surgical evacuation, to minimize the blood loss, we can give local methotrexate or systemic, or we can go for the uterine artery embolization also before the surgical evacuation.
See, surgical management, it is 1.5. You can't do evacuation.
Okay, ma'am.
Okay.
So then we'll go for either minimally invasive laparoscopic excision and repair.
Okay. I did a uterine artery embolization actually because it's 2 previous cesarean with so high EA&7, and even while dissecting off the the bladder down before giving a nick, it ruptured, and this was a pregnancy. So I had put a balloon in there and inflated it so that you had a surface on which to dissect the bladder down, because these 2 previous cesarean, it becomes a little difficult to do the dissection in those situations where you have so much of vascularity with the pregnancy there. And just even before I could open the myometrium, it got opened on its own. You see the balloon there? And then I could suture it, and she didn't want a pregnancy. With all this, we did a tubectomy. Now coming to what to do, this is a new classification, greater than 3, 1 to 3 and 1 or less. So whenever this HCG is more and the lining is thick, it's always better to do a uterine artery embolization followed by a laparoscopy. And if sometimes even the role of medication, this is the new thing now, you can give a combination of both mifepristone and methotrexate, and then go ahead either with a suction or you can do a hysteroscopy removal, but it's 1.5, it's better to go ahead with a laparoscopic.
Now the case number 4. 29 years old, G4V3L3 was referred from a nearby hospital, and she has got severe anemia, yellow mass protruding from the ost, and she underwent a surgical abortion. What is the diagnosis?
Ma'am, this is the uterine perforation, ma'am. Diagnosis is uterine perforation, and the omental part is coming out through the os, ma'am.
Okay. Then how will you manage it?
First, I will resuscitate the patient, ma'am. I'll arrange the blood and I'll plan for emergency laparotomy, ma'am.
Okay. And then if you have to
and I'll inform to the surgical team also if there any intestinal perforation.
And see for the uterine scar also?
Yes, ma'am. Any site of the site of injury also, and I'll repair according to the site.
Okay, thank you.
I'll repair the uterus also, the rent. This is a 30-year-old woman with renal disease on dialysis twice a week. came with 7 weeks of amenorrhea. Her BP was 140/90 and she was on AC inhibitors. Hemoglobin was 8 gram%. She was taking injection erythropoietin for anemia. A scan showed an intrauterine pregnancy of 7 weeks. Would you continue this pregnancy?
We have to take a complete history. She is 30 years old, whether she has...
She has one child. Actually,
She has one
child and it was a cesarean.
In a normal scenario, the pregnancy should be there in a patient with CKD once she gets a proper donor, and even after kidney transplant, she must be stable for 1 year on immunosuppressants. And but since she is now pregnant, the incidence of CKD in a reproductive age group is around about 3%. So if she wants to continue with her pregnancy, we have to tell her all the pros and cons. Like, she is already on antihypertensive drug, she is already hypertensive, and she will be having more complications due to hypertension. Number one. Number two, and she is already on dialysis now. The dialysis, even this has to be continued, and she will be having more morbidity. And but if she wants that, she doesn't want this pregnancy because she is already sick, then we can go for, I think we should go for this surgical evacuation rather than medical termination, because with medical termination...
One minute, we'll go to that a little later, medical or surgical, but our advice should be to go for a termination. We shouldn't be telling her the dialysis twice a week. That will make her renal function even bad.
And with pregnancy, she will be more bad.
Yes. So better we should ask her to terminate. That should be our advice. If she is on AC inhibitors, she is hypertensive, she has anemia, so it's better we terminate the pregnancy. That should be our advice. If she wishes to continue, that is her option and her risk has to be explained. Now we come to termination. Well, if you are terminating this pregnancy, what would you like to do? Would you do a surgical or a medical?
Ma'am, I would like to do a surgical evacuation.
Why?
Because otherwise with medical termination, she is going to bleed for minimum of 10 days. And already she is on dialysis. There are more chances of infection.
She is diabetic, she is anemic, she is hypertensive.
Infection.
So surgical infection, even that will be more. But if somebody wants to do a medical or she doesn't want to do a surgical abortion, then we have to keep in mind that whenever we are using misoprostol, it has patient with end-stage kidney disease on hemodialysis have high plasma level of active metabolite of misoprostol acid. So it is better to keep the dose at a lower level, and oxytocin can be given in the usual dose. And one more thing, whenever they have renal disease, we have to see which antibiotic to give. We have to be very particular in the antibiotic what we are giving, and always get a nephrologist on board so that you know what to do. Okay, actually this patient went on and continued the pregnancy. We had to do the dialysis 3 times, even after explaining. She was polio affected, used to come with a wheelchair, in a wheelchair. She did, she continued. We had to add 2 more antihypertensive. BP went to 200 by something, and had to do a cesarean with tubectomy at 33 weeks.
But still you did it, you managed it. That's great.
I mean, it was real like a time bomb. And she had no complaints. She would come with a BP of 200 and no complaints.
Because they are used to that BP, no?
Yeah, maybe. And what contraception would you be giving? We said, I think there's some problem with the slides. They put the old block. Okay. What contraception would you be giving this patient? That's important because we told her not to get pregnant. We aborted the pregnancy. What contraception will you tell her? I think the other panelists also can answer. In a CKD patient, what is the contraception you would be using? Would you like to give her a OC pill?
Progesterone only pill we can advise.
Yes, OC pill you should not be giving because is hypertensive also. Yes, and yeah, and even POP, progesterone would be okay. You can put a loop also. Yes, and better to put a Mirena. See, if you are putting a copper T again, she will bleed as it is anemic. So better to put a Mirena where her bleeding will be less. You conserve even that. And most of people on dialysis, they have very irregular periods. Actually, she didn't know that she was pregnant when she came. because it was 3 months or something amenorrhea and it came to be 7 weeks. Why? Mirena is a good option for. That is okay, spotting is okay, at least they won't bleed. We can counsel them and see these people with the dialysis and all, we don't know how much. You can tell them that option, yes, but Mirena would be a better option for them because they come for dialysis and and they are the people who are waiting for transplant. Yes.
Function comes to normal, so we can ask her to continue the pregnancy. And then is there any residual impairment in the left ventricle function? Obviously, like pregnancy should be terminated.
So what is the high risk of relapse in this pregnancy?
So like ma'am, after like it comes left ventricular function comes to normal, so risk will be around 21%. And then still she's having left ventricular dysfunction, so like it go for around 44% of relapse.
Yes, contractile reserve is we have to do dopamine stress test. Yeah, you have to see the left ventricular function, and the normal contractile reserves identifies them that less risk. Grand multipara has a 10 to 0.5% chances of recurrence. So in this, what contraceptive? This one is other one.
But still in this condition, it is better to advise her to terminate. Yes.
Okay.
We should advise. If she continues, that's up to her.
Then what is the contraceptive advice we'll give to this?
Again, for this one, only pills, and we can give for injectable DIMPA, DMPA. Estrogen we should not give.
You should not give, yes. What about sterilization?
If they are willing, family is completed.
Better husband can go for sterilization. Yeah.
Okay, regarding this, since it is having heart problems, so antibiotic prophylaxis is to be noted, and sterilization of the partner for sterilization is better advice, because for her to undergo any surgical procedure is risked. Next,
I think is the last case. This is a primary gravida with 6 weeks of pregnancy with HIV positive status with unplanned pregnancy. Comes for termination. She is on treatment for HIV. Is HIV an indication for termination of pregnancy?
Ma'am, HIV is not an indication of MTP.
What are the reasons why these people are scared? Most of these women will come to you, they are on medication, their CD4 count will be good, even their viral load will be negligible, but still they come, not negligible, maybe on the lower side, still they come and ask you that I want to go for an abortion. Why do they ask? What is the important thing? You have to counsel them.
They want abortion.
What about the
transmission, maternal transmission to the baby?
Yes, she is on treatment. So what is the risk? How much is the percentage of transmission? She can very well continue with the pregnancy, but if case she asks for a termination, okay, what are you advising her? She has a right? We have to treat her like any other woman who comes to us. Why surgical? Why not medical? Why should you do a surgical evacuation at 6 weeks? No, I will not. Yes,
I will beg to differ.
Yes.
Actually, HIV has already an immunocompromised state, so surgical evacuation might complicate further. So we would rather go for medical abortion.
You'll go for a medical abortion, but you are telling she has some inputs. What does she want to say?
Medical method using misoprostol has side effect of vomiting.
So you have to be careful when you take she's taking misoprostol.
Vomit, and the efficacy of the HIV, that medication, the efficacy will be less, ma'am.
What will you do then? If she vomits within what time, you have to repeat the dose. Even if you think she vomits within 1 or 2 hours of taking the HIV medication, you have to repeat the medication.
Yes, ma'am.
Okay, repeat the medication. That would be better so that the HIV medications do work. Okay, that's one thing. Another thing, we shouldn't be stigmatizing them. They have the same right. That's what we have to put forward for safe abortion, for respectable abortion, so she can have her choice. And what about continuing the medication for HIV? Should you stop it or should you continue
Have
or
to
increase
continue
the
the
dose?
HIV medication, ma'am.
You have to continue
Yes,
all the
yes, ma'am.
medications what she is taking.
Yes, ma'am.
Yes. Any other thing? The last child, because whichever woman she is a known HIV patient already getting ART, she will continue her ART as per guidelines. Okay. All the 3-drug regimen she has to continue, and we have to be managing the things, nothing to be changed. And in spite, depending, we don't have to do a CD4 or a viral load or anything. If you do and you get whatever the values, you still have to continue. Okay. Thank you very much.
Thank you, ma'am.
Organizers for giving us this opportunity and the panelists.
Thank you for such a wonderful panel discussion. Okay. No, I would like to request Bem Praneshwari to kindly felicitate the panelists.
We'll take a group photo. Their certificates. My phone is here.
It's here, ma'am. This one, yeah.
My phone is here.
Ma'am?
I didn't get it.
It's not here. Next, we'll be having the Kamini Rao oration, and for this, I would like to call upon the respected chairperson.
Actually, excuse me, there is some modification of the session because flight timing and also the legal aspects of the MTP will be done after this.
I would like to call upon our respected chairperson, Dr. Alka Pandey, ma'am, Vice President FOGSI, and Dr. M. Rameshwar Singh, Professor and Head Department of RIMS and Vice President IOGS.
Good afternoon, everybody. In this oration, we have our eminent speaker, Dr. Sanjay Das Gupta from Kolkata. Just to mention a few about speaker, Sanjay Das Gupta is a clinical director, Genome Fertility Center, Kolkata, and is a managing committee member of BOGS 2023 and 24, and executive committee member ISR Bengal 2022-24. He is a clinical examiner of MRCOG Part 3 examination, and he is the winner of Professor Geoffrey Chamberlain Award RCOG World Congress London 2019. May I request Dr. Dasgupta, Sanjay Dasgupta, to share your experience.
Thank you, sir, for your kind introduction. At the outset, I'd like to apologize for being late because of the delay of my flight. So greetings from Kolkata, from Bengal Obstetric and Gynecological Society. I hope Most of you attended our last year's AICOG at Kolkata, and in fact, just yesterday we finished our state conference of our Bengal Obstetric Society. So just I had no other option just to arrive today morning here. So thank you, IOGS, and thank you, FOGSI, for inviting me here. Now, we know this chart since our undergraduate days. That is, ovarian reserve declines as the woman gets older. But why I have put this chart? Because sometimes women have idea that, doctor, when you are stimulating my ovaries by ovulation induction, IUI or IVF, you are basically depleting my ovarian reserve. Is it true? Remember, some follicles are destined to undergo atresia, whatever you do. So when we are stimulating the ovaries either directly by gonadotropin or indirectly by letrozole or clomiphene, we are basically rescuing some of the follicles from undergoing atresia. Therefore, by stimulating the ovaries, you are basically not depleting the ovarian reserve. Okay. So comes the terminology. Ovarian reserve, ovarian response, these are something different. Ovarian reserve means the quantity and quality of the eggs remaining inside the ovary. Remember, both the terms quantity and quality are important so far as the ovarian reserve is concerned. And ovarian response means the number of eggs you are likely to be retrieved during stimulation of the ovary. And ovarian aging is something different. Ovarian aging means it's a physiological process, that is the continuous physiological decline in ovarian reserve that happens, and that is quite inevitable. Now, there are a number of ovarian reserve tests, but most commonly used are 3 A's: age, AFC, and AMH. Why I have put age here? Because remember, age is the most important factor. Often women have idea that I'll do IVF and I'll counteract the age-related decline in fertility. This is not true. If you see this chart, the bold line represents the success rate of IVF using own egg. You see, it declines as the age increases after 35 and decreases sharply after 40 years. The dotted line represents the pregnancy rate using own donor egg. So it remains relatively stable. Therefore, we cannot avoid the age-related harmful effects on fertility. Then comes FSH, but FSH, you know, it varies in between cycle and throughout the cycle. Therefore, single abnormal FSH is of little value in women less than 40 years. Then comes antral follicular count. You can measure it in the laboratory within short period of time without any blood test. But again, it represents the number of follicles that can be recruited in the current cycle. But problem is that man behind the machine is important, as well as the machine through which you are checking it is important. There are some people who are advising to check it by 3D or sono AVC, but this does not seem to have much advantage over conventional AFC measurement. But AFC measurement is particularly problematic if you have ovarian mass like endometrioma. Then comes the hot cake, anti-Mullerian hormone. It correlates with other ovarian reserve markers. The advantage is that it's independent of hypothalamo-pituitary axis, and it is much more sensitive and specific than other markers, and in fact the decline in AMH occurs much earlier than rise in FSH. If you see this chart, AMH is mainly secreted from preantral and small antral follicles, where it prevents recruitment of the follicles. Whereas FSH comes later in the gonadotropin dependent phase of the cycle, that is FSH mainly occurs in the antral follicle. Therefore, AMH helps in prevention of unnecessary excessive recruitment of primary follicles. It reduces the sensitivity of FSH, therefore it preserves follicles, and thereby indirectly promotes the monofollicular development. Now, can AMH vary? Yes, AMH can vary throughout the period, but for practical purpose, it remains more or less constant, so therefore you can measure it any time during period. And in between the cycle, also it remains fairly constant. In clinical chemistry, the variability of any parameter within an individual is described in terms of intra-class coefficient, ICC. Higher the ICC, lower is the variability. If you see here, the coefficient of AMH is very high, therefore variability is low, whereas the coefficient of FSH is minimum, therefore the variability is high, and AFC lies in between. Therefore, AMH remains fairly constant throughout the cycle. There are different factors which can affect the AMH. In clinical practice, most important one is you are likely to get low AMH. You have suppressed the ovary using GnRH agonists for long period of time, like in endometriosis or long-term use of OCP. Therefore, don't check AMH when patient is on these medications, and immediately after pregnancy termination, AMH is likely to be low. And we know in PCOS, usually the AMH will be higher. There is a multicentric study by Dr. Kaveri Banerjee who found that if the woman complains of short interval between period, if the period is happening within 21, 22 days, then she is likely to have low ovarian reserve represented by low AMH. But in contrast to common perception, AMH does not vary according to smoking, lifestyle changes, cell phone use, etc. Therefore, these do not seem to have any effect on AMH. The question is, how low is too low? There is no unanimous decision. Some people are defining low AMH as less than 0.1, some are using 0.9, 1.2. But ideally, because AMH declines as the age increases, ideally AMH should be measured or expressed in terms of percentile, just like fetal medicine people, they describe fetal growth in percentile. For any age, if the value is less than 10 percentile, it should be regarded as low AMH. How far AMH declines? Contrary to common perception, as the age increases, the decline of AMH decreases. Still it declines. Therefore, as the age increases, you are likely to get low AMH. But sometimes, I am sure you all have found that ultrasound is showing very good FC, but AMH is low, and vice versa. Why does it happen? Number one, the technology. From which lab you are checking the AMH, and which person is checking the FC, and from which machine. If it is true, then it usually carries intermediate prognosis between true ovarian reserve patients and good ovarian reserve patients. But why does it happen? AMH is like bank balance, the money you are having in your bank, that is the follicles that can be stimulated later on. But AFC means the money you are having in your purse, that is the follicles that can be stimulated in this cycle. Therefore, this discrepancy can happen sometimes. As I said, AMH is assay dependent, so it's ideally we should ask the lab through which assay they have measured the AMH, and there are different assays, but most commonly used one and the most accurate one is this Beckman-Coulter assay type 2 AMH ELISA assay. Which one is better, AFC or AMH? This study found that AMH declines earlier than AFC, and reproducibility is better. Suppose you are advised to check the AFC of the same woman in number of cycles. I am sure you will report, some cycle you will report it is 5, some cycle you will report 6. Therefore, the reproducibility of AFC is lower than the reproducibility of AMH. Therefore, they found that AMH is better. Now, in this study, they followed up the women after endometrioma surgery. They found that AMH declines steadily after endometrioma surgery, whereas AFC remains relatively constant. Therefore, if you rely on AFC, you will have false impression that ovarian reserve is intact while it is declining. In contrast, this study found that if you have good AFC but low AMH, then your prognosis is better than if you are having low AMH but high AMH and low AFC. Therefore, they concluded that AFC is better than AMH in predicting the poor ovarian reserve. So, we still don't know which one is better, AMH or AFC. Till now, I discussed all the points regarding the quantitative ovarian reserve. What's about quality? No test can predict the quality. Yes, age can give some idea. Why age is important? Because as the age increases, the quality of egg declines because the increased risk of aneuploidy. If you see here, when the woman's age is less than 35, you need only 4 metaphase oocytes, 4 mature oocytes to get one blastocyst, one euploid blastocyst. But if the age is more than 42, you need at least 20 metaphase oocytes to get one euploid blastocyst, which is just like squeezing water from stone. $1 million question is, if AMH is low, can you say that you can't conceive, you are infertile? This study followed up the women who were not infertile. They were trying for pregnancy for less than 3 months. And they followed them up and they found that in all cases, AMH low, AMH normal or AMH high, time to conception remains same. If you see from this Kaplan-Meier curve, these lines are overlapping. Therefore, low AMH is not the marker of natural fertility. Therefore, even with low AMH, she can conceive naturally and her fertility potential is not less than women having normal AMH. I am sure you all must have found some women, 41-year age, AMH very low, previously egg donation IVF failed and she conceived naturally. So if AMH is that important that we should say that AMH is low, you can't conceive, then how they can conceive? Therefore, low AMH does not mean egg donation. Although unfortunately we see often left and right women are told that you take egg donation because your AMH is low. Because this is why, because the predictive power of AMH is low regarding the cumulative live birth rate. Therefore, we should not withhold the treatment just because of low AMH. This study, this curve is something called receiver operating characteristic curve. If any parameter is on the left hand side of this diagonal, red diagonal line, the accuracy is higher. You see, regarding prediction of ovarian response, all the parameters are lying on the left hand side, AMH, AFC, everything, and they are overlapping. That means adding AFC or FSH to AMH does not help much, but definitely AMH has good accuracy in predicting the ovarian response. But what's about pregnancy? See, all the curves are overlapping with this diagonal line. Therefore, AMH is a poor predictor for natural for pregnancy and live birth rate, be it natural pregnancy, be it IVF. Therefore, AMH has its role only in predicting the ovarian response. Why prediction of ovarian response is important? We always tell that IVF is very much stressful for the couples, but remember IVF is equally stressful for the IVF physician because we don't know whether we will be able to stimulate the ovaries optimally, whether we will be able to collect the eggs, whether the eggs will be of good quality, whether we will be able to form the embryos. Forget about pregnancy and live birth. Therefore, we need to predict the ovarian response. What happens if a young woman with low AMH undergoes IVF? This study included women with less than 38 years. They found that if AMH is low, your oocyte will be lower, but the chance of blastulation, aneuploidy rate, and the chance of getting euploid live birth are similar. Therefore, low AMH in young women carries good prognosis. Therefore, we should not withhold treatment. What's about older women, more than 36? Again, this study found that if AMH is low, even in older women, it does not carry bad prognosis. But they found that is the age. Age is the only predictive marker that carries the worst prognosis. Therefore, it's the age rather than AMH which affects the quality of eggs. Now, this study combined younger and older women both. And they categorized the women according to AMH less than 1 and more than 1. They found that in young women, prognosis is good if you are able to form at least one good quality blastocyst, maybe after repeated stimulation. In young women, they found that it does not matter whether AMH is low or normal because the pregnancy rates, live birth rates were similar. However, in older women, if AMH is low, the pregnancy and live birth rates were lower. Therefore, they concluded that AMH is definitely a predictor of live birth, but only among older women, not in younger women. So we talked about poor responder, but what is meant by poor responder? In 2011, ESHRE came with Bologna criteria. Just like we have Rotterdam criteria to define PCOS, then they came with Bologna criteria, that is any two of these three should be present, that is advanced maternal age more than 40 or any other risk factors like chemotherapy, pelvic radiation or surgery, previous poor response less than 3 oocytes retrieved after IVF stimulation, or AMH is low or AFC is low. If two of these three are present, she is said to have poor response or is having poor responder. But this definition had problem. It assumed one size fits for all. It's not true because in young women, we already said young women with low ovarian reserve definitely have better prognosis than older women with poor reserve because age is the most important factor. In fact, sometimes good ovarian reserve does not mean good response. You can have bad response and vice versa. Therefore, this Italian group suggested this Poseidon criteria published in 2016 where they categorized the women according to age, previous ovarian response, and the AFC or AMH. Basically, there are 4 groups. Group 1, young women, good reserve. Group 2, older women, good reserve. Group 3, young women, poor reserve. And Group 4, older women with poor reserve. Why this categorization is important? See, in Group 1 and 2, they are having good reserve, good AMH, normal AMH. In this case, you expected good response, but you did not get it. So, they are unexpected poor responders. The reason may be receptor polymorphism, which is not easy to check, or there may be some asynchrony, that is, some of the follicles are growing faster than others. Whereas in Group 3 and 4, they are already having low AMH, so you did not expect good response, so they are expected poor responders. And the reason may be age, unexplained, or maybe some chromosomal anomalies like karyotype or Fragile X mutation. On the other hand, Group 1 and 3, they are young women, so they are at lower risk of aneuploidy. Whereas in Group 2 and 4, they are older women, therefore the risk of aneuploidy is higher. Therefore, each group is different. And in fact, it was found that the cumulative live birth rates decline steadily as we move from Group 1 to Group 4. So, how to stimulate these ovaries? I am not going into details. There are a number of stimulation regimes are advised, and all the authors are claiming that their one is the best, but there is no consensus. No one is foolproof. But it is accepted that there is no use of stimulating the ovaries using more than 300 recombinant FSH, because you can't push these ovaries harder. Sometimes we tell the women, you have low AMH, even if you conceive, you are at risk of having miscarriage and you cannot have live birth. Is it so? This study included the women with RPL and control. They found that RPL women are having lower AMH. Therefore, they thought that if AMH is low, the risk of subsequent miscarriage increases. In contrast, this retrospective study conducted in women who underwent IVF-FOGSI, they found that miscarriage rate, live birth rate, rate of non-visualization of pregnancy, all were similar between low AMH, normal AMH and high AMH. Therefore, they said that low AMH does not increase the risk of pregnancy loss after IVF-FOGSI. Then came this study. They included women with unexplained RPL. All of them underwent pre-implantation genetic testing, categorized them according to AMH, and they found that yes, aneuploidy rate was higher in women with low AMH. But when they did subgroup analysis, they found that aneuploidy rate was higher in women with low AMH only when they were older women. In younger women, the aneuploidy rate was not different. Therefore, they concluded that low AMH was associated with increased risk of embryo aneuploidy only in older women. Therefore, the effect of age is much more important than the effect of AMH. But does that mean that if the woman AMH is low, we can tell the woman, go home, try naturally, come to me after 5 years? No, this is not. Because AMH is an earlier predictor of premature ovarian failure. Because I have said that AMH declines earlier than rise of FSH. In fact, sensitivity or specificity of AMH to define premature ovarian failure is much more higher than that of FSH. In fact, this study found that if you are using this normogram, if you know the age and the AMH level, you can predict at what age she is going to develop menopause. For example, if the age is 32 to 34 and if the AMH level is 0.52, she is more likely to develop a menopause by 54 years of age. Why this happens? Because of fixed interval hypothesis. Because in human being, despite evolution, the interval between decline in fertility and the time of menopause remains relatively constant. Therefore, their AMH definitely helps in decision making. Therefore, we should not give overemphasis to it, but at the same time, we should not ignore it. But we should not take the decision only based on low AMH, because we have to see the overall scenario, the age, the most important factor. How long she is trying for pregnancy, because as the duration increases, the chance of natural conception decreases. Previous treatment, what did she receive? Male factor, tubal factor, other pathologies that may need surgical correction like fibroid, endometriosis, hydrosalpinx. And most importantly, what we should not ignore, what the couple wants. This is the most important thing. Therefore, low AMH does not always mean she requires IVF. But if there is low AMH and tube block, in that case, it may be more prudent to go for IVF directly rather than trying laparoscopy. If there is associated male factor and low AMH, we should avoid repeated IUI. But what to do? If all the factors are normal, tubes, pumps, everything is normal, but AMH is low. In that case, we should treat the woman having unexplained infertility, but definitely we have to expedite the treatment. Yeah. What happens? We see that often women are changing one doctor after another, and all the doctors are giving some different brands of letrozole. Therefore, we should avoid it. We should expedite the treatment. If she receives letrozole, we should go for ovulation induction in gonadotropin. If that fails, then we should go for IUI, then IVF. Therefore, we should change the treatment. Only 2 or 3 couple of slides. Okay. Now, often we blame ourselves because in surgery of endometriosis, we are reducing the AMH. Is it so? This study compared the women with endometriosis and women with having male factors. They found that AMH declines steadily in women with endometriosis even if you don't do any surgery. Why? Because endometrioma itself damages the ovary and declines the ovarian reserve. This is the mechanism, something called error, endometrioma related reduction in ovarian reserve. But does that mean that you should not do surgery if the woman is suffering from severe pain, there is large endometrioma, but OMH is low? We should not take decision based on AMH. According to this review, you can perform surgery, but take some precaution to prevent ovarian damage, particularly damage to the ovarian hilum. Role of adjuvants. Market is flooded with DHEA. Almost all the companies are coming with DHEA. According to Cochrane review, DHEA in these women can improve live birth rate, but overall quality of evidence is low. Again, Eshe suggested that we should not use any adjuvant. Having said that, the WHO said that you can consider DHEA, testosterone growth hormone, for short period of time. Remember, short period of time. Again, this review by Dr. Mohan Kamat from CMC Fellow published in Fertility Sterility found that most of the adjuvants used in the market are of no value. They are only increasing the cost of the treatment. Therefore, we should be very much cautious when we are advising this treatment. Now, these questions remain unanswered, whether in women with poor ovarian reserve we should do ICSI for all, whether we should do blastocyst transfer, J5 transfer, whether we should try pre-implantation genetic testing, whether we should do repeated stimulation, then do oocyte pooling and embryo banking. There are some experimental therapies like in vitro activation of oocytes. Some people are doing mitochondrial transfer, and there are some centers who are claiming very high success rate of intra-ovarian PRP, but none of them are still supported by very strong evidence. Social egg freezing can have some role, but unfortunately these women often present in late 30s when the ovarian reserve is still definitely low. Therefore, social egg freezing have little role to help these women. Finally, some women opt for donor egg, maybe because of financial reason or after experiencing repeated failure. Some women go for it after seeing the reports of high FSH or low AMH, but we don't know how low is low and how high is high. But it needs counseling, and you know this recent ART Act has restricted the availability of donors. So in a nutshell, AMH definitely helps to predict the ovarian response. AMH help you in making the decision. But AMH cannot predict egg quality, AMH cannot predict pregnancy rate, AMH cannot predict the live birth rate. Therefore, low AMH does not always mean egg donation. In fact, low AMH does not always need IVF. We have to see the overall scenario. You should not take the decision just based on AMH alone. We can offer adjuvants like DHEA, but short period of time we should not rely on them. We still don't know the best stimulation protocol, and we should avoid the unconventional protocol because they are not supported by evidence. Overall prognosis is guarded in women with low AMH only if the age is more than 35. Remember, in infertility practice, we are treating the women, rather we are treating the couple. We are not treating the numbers. We are not treating that we will treat you because your AMH is 1, we will treat you because your AMH is 0.5. We are not treating the numbers. So you should stop this number again. At the end, I have to say sorry because I could not explain this low AMH science in simple language because even I did not understand it properly. Thank you very much for your patient hearing.
The estimation of AMIs is most appropriate for the evaluation of the ovarian function in a woman with infertility. And the AMIs is produced from the granulosa sand, so it is 2 to 3-fold rise in the PCOS when compared with non-affected age-matched cohort. So in near future, it may be utilized as a diagnostic marker of PCOS.
Yeah, there are some studies. They are saying that AMH can be just single tune to define the PCOS. There are some authors here.
Dr. Sanjay Dasgupta, you have presented so well.
Thank you, sir.
With a lot of information, new information, it will be much benefited for our PG student. So any questions are invited from the audience. If there are no questions, we'll just conclude the session. Thank you.
Thank you, sir, for the thought-provoking oration. Now I request the chairperson to kindly felicitate our orator. Moving on, we have the next scientific session on medical legal aspects of MTP. For this, I would like to request our chairperson, Dr. C.H. Nabakanta Sarma, visiting professor, Kathmandu University, Nepal, and Dr. L. Bimol Chandra Singh, professor, Department of Obstetrics and Gynecology, RIMS, and past secretary, IOGS, to kindly chair the session.
Actually, for these sessions, there were so many changes, so many, even the speakers, they could not come in and properly, and then we have to deliver their lecture. Actually, this is supposed to be presented by Dr. Disar Sama, chairperson, MTP committee. Because of the unavoidable circumstances, she could not arrive, so I have to deliver her lecture. MTPA has a long history and then so many modification, amendment. Cabinet approved the bill 29th January 2020 and introduced in the Lok Sabha 2nd March 2020 and passed in the Lok Sabha 17 March 2020. Again passed in the Rajya Sabha 16 March 2021 and published in the Gazette 25th March 2021 and implemented on 24th September 2021 and notified on 12th October 2021. The Medical Termination Pregnancy Amendment Rules 2021, Ministry of Health and Family Welfare, that notification. So this is the notification in 2021, and here we have to look into who, when, where documentations. Now, what are the previous law and what are the again edit amendment? So regarding the gestational age, previous law is up to 20 weeks. Now according to this, the indication, first of all, indications applicable to married women only, but in this new amendment, unmarried also can be covered with certain conditions. And gestational age limits 20 weeks. Now it has been increased up to 24 weeks for some conditions like survivors of the rape, victims of the incest and other vulnerable women like differently disabled women, minor, etc. Beyond 24 weeks for substantial fetal abnormalities. Medical practitioner opinion required for termination of pregnancy. Registered medical practitioner till 12 weeks before, now it is increased up to 20 weeks. And till 20 weeks, if two registered medical practitioner, then it is 20 weeks before. Now it is increased up to 24 weeks. That medical board approval after again 24 weeks. Suppose if we have breach of women's confidentiality, before it is only 1,000 fine, now fine and or imprisonment for 1 year. Then who will do any gestation? Registered medical practitioner, recognized medical qualification is defined in the Medical Council Act 1956. That name has been entered in the State Medical Register. Then RAP with PG degree or diploma in obstetrics and gynecology. So who will do the RMP with MBBS degree, 6 months completed house surgeon in OBGY, or at least 1 year experience in OBGY at any hospital that has got a facility, and up to 12 weeks medical or surgical. Then RMP done 25 cases of MTP, out of which at least 5 has been done independently in a hospital established or maintained by the government or at a government approved training institute. So he can do up to 12 weeks and in medical termination up to 9 weeks. Experience in a hospital for a period of 3 months in OBGY, then has done independently performed 10 MTP cases by the medical method of abortion under supervision of a RMP in a hospital established or maintained or training institute approved for the purpose of the government. So in this less than 20 weeks, 1 RMP, then 20 to 24 weeks, 2 RMP opinion. Up to 9 weeks by medical method. At least 3 months experience in OBGY or has independently performed 10 cases of MTP by MMA under supervision of RMP in a hospital established or maintained or a training institute approved for this purpose by the government. And for the surgical up to 12 weeks. Practitioner who has assisted 25 cases. Actually here they mentioned that those practitioner who has short duration course, they have when alone due to even a medical abortion up to 9 weeks and then surgical 12 weeks. Then up to 24 weeks, then we have to be done by PG degree or diploma in OBGY And then having been 6 months completed house surgeon, or at least 1 year experience in the practice in OBGY at any hospital that has all the facilities. Then beyond 24 weeks, medical board is needed. It has to be approved by medical board. Beyond 24 weeks, so medical board, so 2 RMP should perform MTP after medical board approval. The medical board means medical board constituted under subsection 2C of the section 3 of the Act. After rule 3 of the said Act, the following rules shall be inserted, namely 3A, power and function of the medical board for the purpose of the section. So every medical board, every state government required to constitute a medical board. The medical board will consist of the following members: gynecologist, pediatrician, radiologist or sonologist, or any other member as may be notified by the state government. So what is the power of the medical board? To allow or deny MTP beyond 24 weeks of gestation. Only after due consideration and ensuring that the procedure should be safe for women at that period of gestation, and whether fetal malformation has sustained the risk of each being incompatible with life, or if the child is born, it may suffer from such physical or mental abnormalities to be seriously handicapped. So cooperate other specialists in the board and ask for any additional investigation required for deciding on the termination of the pregnancy. So the board is very much needed, and then it has to be the function of the medical board to examine the woman and her reports, provide the opinion of the medical board, inform with regards to termination pregnancy, and a rejection of the request should be done within 3 days after receiving the request. And it to ensure that MTP, when advised by the medical board, it is carried out with all safety precautions, along with the appropriate counseling within 5 days of the receipt of the request of the MTP. Now, where is the site that we can do this MTP? Less than about a week, less than 20 weeks of gestation, to save the life of the mother, to prevent physical and mental injury to the mother, risks of physical or mental congenital abnormalities in the baby, humanitarian ground, and last but not least, a contraceptive failure, married or unmarried. This is the new one. The last one is unmarried, is the new one added. About the 20 to 24 weeks gestation, gestational upper limit has been increased, but in certain conditions only. Who are those? Survivors of sexual assault or rape or incest, minors, change of marital status during the ongoing pregnancy, for example, widowed or divorced, remarry, women with physical disabilities, measure disability as per criteria laid down under the Right of Power with Disabilities Act 2016, 49 of 2016. Mentally ill women, including mental retardations, fetal malformation that has substantial risk of being incompatible with life, or if the child is born, it may suffer from such physical or mental abnormalities to be seriously handicapped. Women with pregnancy in humanitarian settings or disaster or emergency situation as declared by the government. After 24 weeks of gestation, only fetal malformation incompatible with life or risks of the physical, mental abnormalities leading to seriously handicapped. Only after due consideration and ensuring the procedures to be safe for women at that period of gestation. For this medical board, no upper limit. So, so indications after 20 weeks saves the life of the mother to prevent grave physical and mental risks of mental congenital defect in the baby, humanitarian ground. Contraceptive failure is both for married and unmarried. And 20 to 24 weeks, survivors of sexual assault, rape or incest, minors, change of marital status, women with physical disabilities, mentally ill women, mental retardations, fetal malformations, and women with pregnancy in humanitarian setting with disaster, emergency situation declared by the government. Beyond 24 weeks, only fetal malformation. Then where the place where we can do? Hospital established or maintained by the government. In this government hospital, in PHC up to 8 weeks, CHC up to 12 weeks, district hospital up to 20 weeks, medical college, any period of gestations, and up to 24 and beyond. Place approved by the district level committee, if it is a private. Now, very important is documentations. You know, if we fail to document, we are liable to be punished. So Form C, consent Form C is very important. And registered medical opinion form less than 20 weeks is Form 1. Then RMP opinion for 20 to 24 weeks, Form E. Then medical board more than 24 weeks is Form D. We have to fill out. And Form 2 is monthly reporting form to be sent to the district authorities. Form 3 is admission register for case records. So here, this is the form, Form C. Here the first one is, the name is daughter of, the last one is a mentally ill person. This to be signed by the guardian. Then this is Form 1, MTP till 20 weeks, we have to fill up this one. Here name, qualification, registered medical practitioner in block letters. Full address of the registered medical practitioner is needed. And Form 1, as the pregnancy has occurred as a result of failure of contraception, we have to fill up nicely here. Then Form E, 20 to 24 weeks, new form. Then Form D is the medical board above 24 weeks. We have to fill up. And now this is the Lieutenant Governor, National Capital Territory. They have published some government hospital in Delhi. This is the list. And the number C column, the composition structure of the medical board has to be HOD, obstetrics and gynecology, or any senior doctor or chairperson. Pediatrician and neonatologist should be a member. Radiologist, ultrasonologist, fetal medicine specialist, genetics member. Any other specialist as per requirement of the case member. Medical superintendent or administrative officer nominated by the MS convener. For private hospital, medical board, a member from the government hospital shall be nominated. So to say, medical board, it has to be constituted so many members, then their hospital administrators should be there, over and above pediatrician, radiologist, and gynecologist. And one member should be a lady. Form 2, monthly reporting form to be sent to the district authorities. So what modification they have is the weeks of gestation. They have increased from the before form. It is increased up to 24. And the injectable contraception in the advice they have added. And then these are the things between 20 and 24, what are the indications? There had been some modification. Then Form 3, admission register for case record. Here everything his sacred documents, open or not open to all, open under authority of law, and when if there is a demand legally, confidentiality has to be maintained, and it has to become under custody of owner or head of the hospital, preserved for at least 5 years. So here they have added method of MTP here, they have added some, and then in the advice they have added injectable contraception. So consent form say, just remembering, this opinion form 1, form E, form D, and then the monthly reporting, it has to be sealed and kept and enveloped. The offenses, very, very important. All offenses under MTP Act are cognizable, arrest without warrant, non-bailable. Serious offenses and bail is a matter of discretion. That is, bailable means bail is claimed as a matter of right, but it is not allowed, non-bailable. Non-compoundable, parties cannot compromise. Even though that party we won't do, no, they cannot withdraw. Non-compoundable means complaint can agree to take back the charges levied against the accused. It's not allowed. It is cognizable, non-bailable, non-compoundable. So what are the offenses? Termination pregnancy by unauthorized persons. The punishment is 2 to 7 years rigorous imprisonment. Who will be the person to be imprisoned? Persons performing the MTP. And MTP in unapproved place, rigorous imprisonment 2 to 7 years. Who will be the person to be punished? Owner and person performing the MTP. The last, failure of documentation, record keeping, consent, admission register, etc. Fine up to 1,000 plus 1 year imprisonment, the concerned person. Offenses. So, section number 312 IPC. MTP without listed indications. Less than 4 to 5 months pregnancy. Imprisonment up to 3 years and or with fine. Who will be the punishment should be given to the person performing the MTP and the woman. Section number 312 and 316 IPC. More than 4 to 5 months pregnancy, quick with child, imprisonment up to 7 years and fine, or imprisonment up to 10 years and fine. Who will be the person? Person performing the MTP or any other. Section number 313 IPC, MTP without consent. MTP without consent, life imprisonment or up to 10 years with fine. Who will be the persons performing the MTP? So the offenses are very strong. So section number 14 IPC, death due to MTP with consent, punishment imprisonment of 10 years with fine. Person performing the MTP. Then death due to MTP without consent, life imprisonment up to 10 years with fine. The persons to be punished is the person performing the MTP. This is section number 314 IPC. Thank you. So better do something correctly than at all. Better to be safe than sorry.
Finish?
Yes.
All right. Thank you. Professor, wonderful, brilliant overview Of course, you didn't make it the slide. Thank you very much. Anyway, time is running short, and I think we should wind up the next topic because I'm diabetic, little hungry also.
Oh yeah, very good, sir. Even let's skip out.
Thank you, ma'am, for sharing such a valuable and impactful knowledge. Now I request our chairperson to kindly felicitate our respected ma'am. Requesting our chairperson to felicitate. We will take a short lunch break now. It will be a great pleasure if you return to this hall on time. The next session will be starting at 2 p.m. sharp. Please enjoy your lunch.